called Melanoma Site 2. And so thank you, Dick, for being here today.
So advance the slide.
Speakers on, or microphones on.
Push harder here. Well, it's always an interesting task for talk to patients. I give lectures and I'm used to giving talks to physicians, and so it's always a difficult thing. I got to enter the mind of somebody that it wasn't great boxes if they say, well, at least get through to you. This first slide I have here shows two places that I was associated with earlier in my career, which is the University of Pennsylvania and NYU. And medical centers contributed to the field of melanoma. I was fortunate enough to have trained with many people during my career that highly influenced both myself and melanoma research. This arrow is not. Oh, here. Right. See up and down. Okay. So I want to go into a little bit of historical context here. Going back. Well.
David, can you control it for him?
Well, he has to control it.
Yeah, the forward arrow doesn't work.
Okay, up and down. And
Oh, well, that didn't work either.
it doesn't work.
Well,
Check and see if that mic's on too.
so here's the. This is.
Yeah, it's a little bit quiet. You should put it on back on. Can you advance it on the non-presenter mode?
No, it's not advancing.
Oh my God.
1 second.
Yeah. Find out.
If you see that it's not, you have to click through the animations. So this is your clicker?
Yeah.
And just push down to.
Hopefully this will work. Okay. So I just wanted to point out that the Division of Dermatology at UCLA is not a very old medical school, actually. It was just begun in 1956, actually. And the Division of Dermatology there was actually founded from the University of Pennsylvania, or came out from Pennsylvania, and then Dr. Newcomb, who also was very instrumental in the founding of the dermatology. Now, in NY, there were a number of people that were very instrumental in the development of our thoughts about melanoma. One of them is Al Koff, who he brought Mohs surgery in one of the first universities to bring Mohs surgery out of Wisconsin to New York. And John Converse, who was the chairman of plastic surgery there when I was there, wrote the definitive book in plastic surgery. And those two people were very instrumental in the development of skin cancer research at the time. And Kerry and I here at NYU and trained over fellows. Of course, now I've trained over 4 fellows, so it happens to be older. Established the Mohs surgery at NYU, and actually was responsible for many of the trainees in surgery. And I had a review of a paper recently, and they looked at where most of the people had trained during their fellowships. And you can see that New York University produced most of the fellowship directors in the country. Second, and UCLA was second. And so when I came out to develop the Mohs surgery at UCLA, I like to think we brought that culture forward to the West Coast, and there's this real culture at UCLA regarding that. And the Cleveland Clinic was one of the centers as well. They have a clinic that produced most of the fellowship directors in the country. Now, I'd like to define melanoma in situ. Wallace Clark was a professor again at Penn. Keep going back to Penn here, but when I was a resident there at Penn, there's this curious note that was on the board. Wallace Clark, and he said, we're doing research on melanoma. He was at Temple at the time, which is right across town. We appreciate any specimens to do our research with. This was the beginning of people's thoughts about if you could use the depth of melanoma to predict diagnosis. It wasn't until that time that people could think this way. Is there a way to go backward? No. Maybe I go backwards.
Raise the volume too on the speaker.
Yeah.
The microphone is full, so we're gonna have to speak to the room. It's a small room.
I'll speak up.
Thank you.
Yeah, here. So this basically shows you what Wallace Clark envisioned here, which is basically, if you look on the left side here, you can see these melanoma cells on the top layer of the skin. And as you progress forward, you can see where they go into the skin. So this gave us the idea that the melanoma invasion correlated with what happens to the patient in the future. And he was the first one to get into that. So melanoma in situ, we look at, or at least I look at, is 2 different animals. One is what we call maligna, and the other is non-maligna. And maligna maligna generally occurs as sort of a brown patch, and then it evolves over a long period of time. And it's often associated. Yes. It evolves over a long period of time. It's associated with a solar LIGO. It's often dimensions on the face and has regular borders to it. It sort of looks different. I'll show you some examples. Non-LIGO malignant, on the other hand, often is associated with moles, which is on the trunk. And these types of melanoma usually are more serious than LIGO malignants. shows a picture of FDR when I go malignant on it, over his eyebrow there, which you can see in photographs. It evolves very slowly at times. On the left, it's relatively small, as you move to the right. So these evolve very slowly over, but eventually they go into a phase where they go down in depth, as I showed you on the slide. Here's some examples on the left there with these irregular borders or round, large brown patch on the face, and non-malignant malignant over on the right, which are sort of smaller lesions generally, although they can be large, but generally small lesions. So how do we detect melanomas? Well, they talked about the ABC melanoma. Again, this was a concept coming out of NYU and Al Kopp's group. Symmetry, border, color, diameter involved. So these are the things that are taught to others out there and other physicians. So you can see these examples here. So the malignant lesions have a more regular border. The colors look a little different. So when we look at somebody's back that has a lot of moles, we'll look for the funny looking moles, basically. And those are usually the melanomas. So how do you really fine tune looking at melanomas? Well, another concept came out of NYU again, which is the dermoscopy, or dermatoscopy, more properly pronounced, from NYU. And we have a special gadget that we can look at things in the office with, which will give you, a more magnified view of what it can. So you can see the different colors and the borders. You can make some decision about whether or not you need to biopsy that lesion or not. Because somebody comes in with many moles in their back, it may be very difficult to actually figure out which ones to biopsy. So there are good ways that are available now that physicians have. Total body photography is another technique which again came out of NYU, and this is really reserved for patients that have had melanomas that have lots and lots of moles, and it's almost impossible to monitor this because they have so many moles, nobody really, and they frequently have a genetic predisposition to melanoma. And so you can take 25 views of the body photographically and you can serially follow these patients over time. And unfortunately, in this area, in California, nobody really does that. Mainly because the insurance companies want to have to pay for it. So that's another problem that we have with some of these patients. And it's also very time consuming to do this. Take 20 and then monitor them. And we did it for a while, just a disc with all the pictures on it, and try to monitor the situation, but it's very difficult. Sloan Kettering in New York has a good program where they do this with patients, but most universities don't get into this. So here's an example of a lesion that was sent to me, a tiny lesion on the nose, relatively inconspicuous but still there. And we took this off. You can see the border I have. I circle the lesion and then I take a little bit of a border. And this patient was sent in with another gadget that's out there called the mole analyzer. And the mole analyzer is a gadget that actually takes a photograph of the lesion and then they put it into some computer program and analyzes the shape of the lesion, the colors, and this is going to tell you whether it's a melanoma or not. And if it's red, it's a melanoma, and if it's green, it's not a melanoma. But unfortunately, most of these lesions that are done with these mole analyzers end up in the yellow zone here, which it's just kind of in between. You don't know whether or not it's a melanoma or not. So these techniques are not quite as definitive as you might think. It sounds good, but it's not quite as definitive. Another idea is this DermTech tape test, and representatives outside here. This is proven to be a little bit of value for us. You put some tape on the skin and it detects some melanoma, genetic antigens there, and it's positive. That's good. But sometimes these tests are not so reliable. This is a patient that is crank positive, which apparently doesn't stand a great chance of melanoma that proved to be a melanoma. Treatments for melanoma. Well, there are various options for melanoma in situ anyway. The standard treatment to excise melanomas is a 5 millimeter margin. And how is the 5 millimeter margin, how is it decided? Well, it was decided by some committee that sat around one day and decided 5 millimeter margins might be a good idea. And that's what this committee concluded from the NIH. Now, actually, in the end, it's sort of proven to be more or less right. But initially, that was just a guess. To let you know that. Topical chemotherapy is another thing that's been mentioned. So, Eldera, Efudex are two types of topical cream that can be used on very superficial melanomas. The problem is these superficial melanomas actually go down through the hair follicles. I showed you a picture of the melanoma in situ just being the top layer of the skin, but actually, I didn't show in that picture. I didn't show you that there were hair follicles that go down in the skin and see melanoma in situ. You get down into the hair follicles, and then they repopulate up through the skin, even though you've used one of these topical therapies. And then there's Mohs micrographic surgery, which is what I do full time. That just a second. So this is basically staged excision under local for melanoma in situ, and this is done with frozen sections without immunostains. Nowadays we use immunostains, and I'll show that to you, which we think is a pretty good advance actually in getting these lesions out. Fred Mohs, who developed the technique of doing Mohs surgery, eventually first called it chemosurgery, and actually initially he used a paste, but that's been long since not used. The main thing he really discovered was this pathologic examination of tissue that's done in a certain way. It's different than what's done routinely for when you take tissue off the body. And this was his first paper on Mohs surgery. His patients always ask me, how long has Mohs surgery been around for? This is from it's not his first article. His first article is 1941. This is his first article on chemosurgery for melanoma, which he published in 1977. And he went back and reviewed his case. His series is very favorable compared to the real literature. It was sent to us of a persistent lentigo on the face. And you can see the crusted area of the graft, which was put down after an excision and was put on the edges for melanoma. And more inferiorly there, which I'll show you, there was also a previous skin graft that was done that was also, which was apparently negative, but actually it recurred at the time. This was the graft that was done a few years before. So then, and took this. So in stage 1, we take out the lesion, the borders, and we look at all those edges to make sure everything's clean on the edges. And then you can see in these different stages where I find the tumor, I take increasing amounts of tissue on the edges, so we gradually can detect exactly where that tumor is in the skin and going out from the edges. It's a more accurate technique for excising not only melanomas but other skin cancers. And this is stage 4. Finally, we get everything out. And I left the prior graph here just for the dressing changes for the patient. And then we took that off eventually. This shows you a cross section showing the melanoma cells, little is in the top layer of the skin here. This was the eventual extent of this tumor. I took out the previous skin graft materially on this patient. And then we went ahead and reconstructed this patient. And anything else that we learned to do over time. Initially, when I trained in Mohs surgery, we didn't really understand how to reconstruct a lot of these. This just shows you the technique that I use to do this, which is this rounded flat with multiple pieces of. And this is a later view of this patient. She had a reason that she would track out exactly where that tumor persisted in the skin. So there are ways of doing this. But the disadvantage is, here's another example of another melanoma that we did recently. I want to go on malignant cancer, this brown patch on the skin, regular borders. You end up with a regularly shaped wound to figure out how to reconstruct this. So the patient looks good. This is an example of the special stains we use now, which are the MART1 stains. The MART1 stain is over on the left, and the typical H&E stain is on the right. You can see how apparent the stain is. We use the sort of green, sort of blue dye stain for the MART1. And it's really advanced our knowledge about taking the melanoma in situ off. You can see the tumors much more clearly with this. And this just shows some of the advantages of using the MART1 stain. One advantage is that the average number of stages that melanoma with surgery has gone down quite a bit. So a series of cases, 1,300 melanoma cases. For the MART1 stain, which we've only done about 40 cases, to calculate this data, our stage count went from 2.94 to 1.76. So the stage count was way down. Because when I was looking at melanomas before without the MART1, I was unsure about, well, maybe this could be a melanoma, maybe it couldn't be a melanoma, so I take more tissue off. So, but now we can take less tissue off with this newer technique. And this is also interesting. This is the cost of doing this procedure with and without the MART. And the MART1 stain now, there's a great decrease in cost for the patients for doing this. The disadvantage is the physicians make less money. We try less stages. But in terms of for the patients and insurance money, the patients, they're going to get less tissue removed and it's going to be less costly. But there are some problems with immunostains, and I think there's a newer technique, we're sort of discovering what some of those problems are. One of them is that not all melanoma is stained with melanoma, it's false negative, particularly the desmoplastic melanomas. And then interpretation takes some experience. It's a little tricky to read these slides, but fortunately, Steve Coker, who's a genetic pathologist over at St. John's, actually was very helpful for us and come over and help us figure this whole thing out. So we're pretty confident now. Initially it's a tricky thing. And then you need additional laboratory equipment to actually do these MART1 stains, and it takes the technicians more time. But irrespective of time, it takes that much more time. Maybe it takes an hour more. It's not melanoma is a superficial melanoma, and really possible by well-trained dermatologists. And it's curable, not invasive, and all margins are, and can be examined by Moses surgery with immunostains. It's a very sensitive area where you really want to preserve tissue. So if you get one of these lesions on the tip of your nose or around the eyelid, someplace like that, it's a very good technique. That's my last slide. I hope I talked loud enough. I know I tend to talk softly. Does anybody have any particular questions they want to ask at this time? Yes.
I'd like to ask a question on behalf of the audience, on behalf of me as a medical oncologist. How critical is it to remove all signs of melanoma in situ on the edge of a melanoma? How likely is it for that residual melanoma in situ to turn into melanoma if left in place?
Yeah, well, that's kind of an interesting question, which
Asking the easy stuff.
Alistair Cochran over at UCLA, I don't know, published early on about this. When he took off melanomas, they would see these melanocytes trailing off the edge. And at the time, he thought that these were benign. And so it's a difficult thing to really say whether those melanocytes at the edge are benign or malignant. But my concept is that you have a certain field with atypical cells, whether they be squamous cells or melanocytes or whatever. And at some point in that field, the cells turn corner and they become malignant. And then you take them out, and then you have these other cells in the periphery. We run the same kind of cells. You take out the squamous cells and see these atypical cells off to the side. And my fellows are pushing and not be too aggressive in those cases. Maybe treat the topical chemotherapy and take them out. Although I've found over time, I may take a section on. It's not going to make any cosmetic difference to the patient. And take some more tissue and be sure. That's basically my concept.
And maybe Dr. Kashani Sabat will address that too, about the molecular biology of melanoma and may become more aggressive or more threatening.
Try it.
You didn't know you were going to talk about that, right?
No, but I'm happy to
Okay, you can make it. Thank you.
Yes.
In your opinion, how long do you think a check should take for an average person to go yearly to the dermatologist? How long should a dermatologist take to check you for melanoma?
Your situation. Well, these days, it's a difficult situation. Because there's an article that was called, physicians have not gotten a income amount that Medicare is giving them. Actually, in 20 years, there's been no increase with the cost of living. And actually, I have to do twice as many cases now than I had to do. It's going up, and reimbursements are going down for physicians. So there's a general tendency today for physicians to spend less time with the patients. And and then we've got physicians that have employ a bunch of PAs running around. There's another thing that's going on out there. So basically, relatively untrained individuals go in and they see something, clinically involved biopsy. Whether they should biopsy or not is another story. So there are lots of problems with that. So there's no real one answer to your question. It's sort of depends on the situation. Certainly, if you've had a lot of skin cancers, then they require more time with patients. Skin cancer or less time. It's head of melanoma, multistreaming melanoma, lots of moles. I think you should probably spend more time, probably about 10 minutes, 15 minutes, maybe something like that. But if somebody has relatively nothing, maybe not so much. Yes.
I had stage 3, I believe, melanoma. Basically had the cells removed to the extent that they could be removed. I've had a brain scan, I've had a full body scan, I've had a scan on my neck, I've had 2 lymph nodes removed. I believe one of them had no melanoma at all in it. And my question to you is this. Does it make sense when one has a decision to make to go into the, I believe it's immuno infusion, if you will, process? They can't find any cancer in any part of my body right now. Would it not make sense, and of course one has the option, to simply say, well, maybe it won't come back again? Can it make sense to basically forego the infusion and have checkups every 3 months, shall we say, to make sure nothing else pops up in order to get it right away if something does arise, and thereby could be any amount of basic after effects that could affect all kinds of parts. I'm conflicted because of the fact that by just simply, if I'm clean, so to speak, based on the scan, why shouldn't I simply have a quarterly evaluation?
To address, we don't have a session actually to talk to you at the break about the individual questions they'll have about their own cases, because each person has. I know, but that's going to take a long time. So I'd be happy to talk to you at the break. Since I'm not on, Dr. Bennett is a neurosurgeon. Okay, we'll do it like that. Because we can move on to the next topic.
But some's our best. That's my answer to the question.
Oh, here. Thank you, Dr. Bennett. Our next speaker is going to be Dr. Zahid Arolu, who is working at Moffitt Cancer Center in Tampa, Florida. And Dr. Arolu is going to be speaking about a class of melanoma that's unique called desmoplastic melanoma, in which she is a specialist.
Emily wants to come up and let me know if they're,
Oh, you're going to announce that.
those are my.
While we wait for Dr. Arolu's slides, we forgot to give do the housekeeping. Anybody who wants more to eat, eat. The little boy's room is on the right. If you go out to the right and then to the left, little girl's room is out to the left and then to the right. So it's like a tuning fork.
Thank you. So my name is Dana Thoreau. I'm a medical oncologist at Moffitt, which is all the way in Tampa, Florida. But I actually did training close by. I was at UCLA for my medical school, and my oncology fellowship was a little further out at City of Hope. So as an oncologist, I typically see patients with more advanced skin cancers and also do their treatment. All right, so I'm going to talk today about desmoplastic melanoma and the role of immunotherapy. So this is a more rare type of skin melanoma. It's actually only about of skin melanomas are of the dysplastic histology. So there's some unique features of this that we'll get into, but typically, hopefully you see on the slides, plastic melanomas can present as sometimes plaques, nodules, or just areas of skin thickening. And as you can see from some of the images, they may not always be pigmented, right? May not always have, a dark color to them as we tend to think of most skin melanomas. And as a result, they can be more difficult to diagnose, and their diagnosis can be delayed, right? They can present at a stage. And they have a strong association, sun damage to the skin from sunlight, and is oftentimes found in head areas and then less common in arms and legs. They also tend to be more common in older and other skin. So typically the median age diagnosis. So a few other features of melanomas, softness under the skin, right, as we were looking earlier at made under into the skin. They tend to be deeper under the skin than other skin melanomas. They have high tumor mutation burdens, right, because of their strong association with sun damage to the skin. I think that leads to a lot of genetic mutations in the cancer cells. The most common of these mutations found in desmoplastic NF1 mutation. So we heard about BRAF mutations, that about 45% of patients with advanced melanoma will have BRAF mutations. They're very rare in the desmoplastic histology of melanoma. In terms of how to identify if you have desmoplastic melanoma, you actually have to look at the pathology report. That's where it will be reported. But it'll be important to look at the pathology from the primary. That may be the biopsy that was done by the dermatologist at the initial melanoma diagnosis, a shave biopsy or a punch biopsy. So typically, if melanoma is of this rare type of histology, that's where it will be reported. Surgical pathology report excisions or biopsies of metastatic lesions like bone, liver, etc., may not always mention that it's of desmoplastic type, but the pathology of the primary, the initial melanoma, would mention it. The pathologist has identified that. Speaking of pathology, in terms of how we actually make the distinction of desmoplastic melanoma from other skin melanomas is essentially how it looks under the microscope. I'll just put a couple of figures here, and hopefully the mouse is showing. But just briefly looking at the difference with how a desmoplastic melanoma appears under the microscope versus other non-desmoplastic skin melanomas. Plastic melanomas, you can see in the dark brown here, that we don't see in most other skin melanomas. And these spindle-shaped cells are separated by collagen fibers, which this really highlights those cells that, again, we don't see in desmoplastic skin melanoma. And there's this stromal reaction called desmoplasia, right, that's seen, and essentially, and some markers as well that helps a pathologist make the distinction of a desmoplastic melanoma versus other types of skin melanomas. So in terms of treatment of desmoplastic melanoma, so currently it's the same as other skin melanomas. Early stage, so stage 1, stage 2 desmoplastic melanomas are upfront surgical resection, and then more advanced, unresectable or metastatic stage 4 desmoplastic melanomas, as other skin melanomas, are primarily treated with immunotherapy drugs. And this here is just a reminder, just from the most recent NCCN guidelines of the various immunotherapy drugs, the infusions that are available for patients with advanced melanoma. So we can see here the single immunotherapy drugs, as again, just a reminder for anyone not familiar, we have the anti-PD-1 antibodies, so pembrolizumab or Keytruda, nivolumab or Opdivo. These can be given as single drugs, and then we also have the combination drugs, nivolumab, ipilimumab, or Opdivo Yervoy. Nivolumab or relatlimab is the most recently approved combination, also known as Opdualag. So what's our experience with immunotherapy drugs in desmoplastic melanoma specifically? So taking a step back, we know that with single agents like pembro or nivo, advanced stage 3 or stage 4 melanoma, the typical response rate, so how likely the melanoma is to significantly shrink with treatment, is about 35 to 40%. Again, those percentages can be higher with the combination regimens, but this is just the nivo. And as these drugs first in clinical trials and then subsequently FDA approved, starting I think in late 2014, anecdotally, oncologists started to notice that the patients who had this rare desmoplastic histology of melanoma seemed to be doing much better than other patients with advanced skin melanomas that were not desmoplastic. So it kind of led to this question, is there something unique with desmoplastic melanoma that we should look into further? So we actually conducted a retrospective case series. So looking at, communicating with different cancer centers across the world, actually, to try to compile, cases of patients with metastatic desmoplastic melanoma who had received immunotherapy. And we actually found 60 patients, and to find 60 patients, given the rarity of this subtype, we actually looked at 10 cancer centers, across US, Europe, and Australia as well. And of these 60 patients with metastatic desmoplastic melanoma, median age was 71, almost all had stage 4 disease, as we can see here. And we found that of the 60, 42 of them, so 70%, had a significant response to immunotherapy, pembrolizumab or nivolumab, and almost a third had a complete response, right? So again, 70%, definitely higher than that 35-40% we tend to see with single immunotherapy drugs in skin melanomas as a whole. So this figure is just, we call these waterfall plots. So each line represents a single patient. And this is how much of a decrease or a increase from baseline tumor size happens with these patients. And actually, as we follow this down, 100% decrease, right, in these patients is essentially a complete response. That means all metastatic lesions on imaging have disappeared, right? Patient has no more radiographically visible tumors seen on their skin. Again, about a third of these patients have this complete response, and the rest having a partial response, or at least a 30% decrease in their metastatic lesions. And now looking at, in the same group of 60 patients, progression-free survival. So this is essentially time without progression or growth of the metastatic melanoma. So it's also an important parameter to follow in patients who are receiving immunotherapy. And these are what we call survival curves. So it's just a way to show all the data in aggregate from these 60 patients. We can see at start of treatment, 100% of the progression. And then as time goes forward, you can see time here, this percentage will start to drop, right? From 100%, it will get lower and lower as patients have their melanoma progress, right, as they start to grow. And what we found was that at a median of 2 years, almost 2/3 of the patients with melanoma, again, these are patients with stage 4 metastatic disease primarily, about 2 years, almost 2/3 of the patients' melanoma had not progressed. And also about 2 years, 75%, so almost 3/4 were still alive and well with receiving immunotherapy for their desmoplastic melanoma. So of course, in oncology, the gold standard is clinical trials, right? So what I was referring to by is like to normally try to test, an interesting observation in a form of clinical trial. And this is what was subsequently done. So this was a study conducted through SWOG, which is one of the cooperative groups through the National Cancer Institute, led by Dr. Karen Chandra at Ohio State University. And this clinical trial had 2 cohorts. The second one we'll get to later, but this cohort was the same group of patients we're talking about, those with unresectable or metastatic desmoplastic histology melanoma who had not received prior immunotherapy, so this was first-line immunotherapy, and receiving an immunotherapy, pembrolizumab, Keytruda, 3-week infusions as is typically given, up to 2 years, right? And the patients would have CT scans done about every 9 weeks to follow full response, progression, whether or not the immunotherapy was controlling, shrinking their melanoma, or if it wasn't. For this clinical trial, there were 27 patients that were enrolled, Multistreaming for their melanoma, median age 75, and 29% of patients had stage 3 disease, rest had stage 4 melanoma. See the formatting got off a little bit here, but that's fine. So if we looked at the primary endpoint of this study, it was looking at complete response rate. So as a reminder, complete response is 100% decrease in size of the metastatic lesion. So essentially no visible disease on sites. And about patients, just like in our retrospective experience, have complete disappearance of all their metastatic lesions from the pembrolizumab they were receiving. And then the overall response includes those partial response, right? So those patients here in blue, right, well, at least a 30% decrease. All together, the objective response rate was 89%. So that's actually, as I'll show you momentarily, is one of the highest, perhaps the highest response rate we see with immunotherapy drugs in all of oncology. Just 89% is quite impressive. And what that's supposed to show is just a reminder of what the response rate is in other skin melanomas, 40%. So this is the plot from one of the earlier pembrolizumab also in patients with all skin melanomas, and then you can see here is only about 35% having this response as opposed to, again, the 89% we saw in this small study of the desmoplastic histology. So just some patient cases and some photographs from patients who were in this clinical trial. So this was a gentleman who had, as you can see here, desmoplastic melanoma on the scalp, and you can see on the PET scan, it had spread throughout the scalp, head and neck area, so was not. And so this is a photograph of how his desmoplastic melanoma looked at the start of the immunotherapy, the pembrolizumab. And then essentially you see the treatment starts October 8th, October 29, that's 3 weeks later. Clinically, the lesions are already starting to shrink. And then another 3 weeks goes by and they are hard to see anymore. And then clinical photographs, and then several months later, the hair starts to grow back over where the melanoma once used to be. And the PET scan as well, as you can see, the dark areas up here on the scalp and all these lesions are no longer seen on the follow-up PET scan. And this was another patient from this clinical trial with lung metastasis. You can see here on the imaging part lungs, and then here's the melanoma here, metastatic melanoma. So looking at the progression-free survival, again, that's that the time a patient will grow. You see that nearly all of you see these little arrows, so these are called swimmer plots. So again, each line is representing an individual patient here. Nearly all of them, as we see with the arrows, their response is ongoing. And so essentially their melanoma remains under control. And we can see with looking at, again, this survival curve, so at 2 years, right, 74% of patients have not had any progression, have not had any growth of their melanoma with the pembrolizumab. And in terms of how that compares, with pembrolizumab, nivolumab, and again, all skin melanomas, the 2-year progression-free survival rate is about 37%, right? So this is data from another clinical trial. So again, we can see here how much more effective the immunotherapy drugs appear to be in the desmoplastic histology of melanoma compared to all other skin melanomas. So the investigators, of course, to try to answer some of these questions of why is immunotherapy so much more effective in desmoplasia, did some additional analyses looking at tumor biopsies, right? So tumor tissue that was available from some of the patients in this trial. And a lot of this is still ongoing, but essentially they found that, as expected, the melanomas have this high tumor mutation burden, right? And that this NF1 mutation was the most common one. Again, each line represents an individual patient, and then the BRAF mutations, again, were very rare. So I think the answer to the question, desmoplastic melanoma is so responsive to immunotherapy. I can't say that I know for sure. Is it the high tumor mutation burden that we see, again, which is, as we'll see in a figure momentarily, is much higher than a lot of other. There are other cancers that have similar high tumor desmoplastic melanoma and don't respond as well to immunotherapy. So that, I think this is part of it, but I don't think it explains it. Is it the fact, the mutation, that it's the mutations are more common? But when we've looked at melanomas, non-desmoplastic with NF1 mutations, right, they do plastic type. Is it something with the histology, right? We were looking at how it looked under the microscope, the desmoplasia. Is it so? We don't know for sure yet, but I think some of the ongoing research that was done from the biopsies and blood samples obtained from patients who are on these clinical trials may help to answer that question more clearly. So just to put this in context, where the response rate, that 89% we were looking at, falls as compared to other tumors treated with single immunotherapy drugs. So this figure is now several years old, but I think still useful. Just plotting that response to single immunotherapy drugs like pembrolizumab, nivolumab versus the mutation burden of a cancer type, right? And we can see various cancers listed here. And we see melanomas, right? About 35-40% response. And melanoma does have more mutations. We see down here, uveoloma, as Dr. Opetsky will be giving a talk on this shortly, having overall much lower mutation burden and unfortunately much less responsive to immunotherapy. But if we try to plot desmoplastic melanoma onto this figure, we'll have to extend our y-axis here, as the response rate is 89%, and I'm not sure if you can see this. This will actually all the way up here, the 89%. So you can see. So if we take back and kind of think in terms of our treatments for patients with advanced desmoplastic, the immunotherapy drugs are FDA approved for all types of advanced melanoma. There's no differentiation between desmoplastic and other. It could be informed maybe which type of immunotherapy drug to consider. So I think immunotherapy treatments for metastatic melanoma as a whole is starting to turn more towards the combination regimens. Right? Say probably this LAG-3 combination is increasingly, as it's been shown to have higher response rates, better progression survival than the single immunotherapy drug nivolumab, singly starting to be utilized as that first initial treatment for advanced metastatic melanoma. Now there's of course the combination, and sorry about this here, there's of course the Opdivo Yervoy nivolumab ipilimumab combination that I think still has an important role. But as you'll see here, even though the response rate is numerically higher than this combination, the toxicity is much more Yervoy. So this here, the grade 3/4 adverse events is essentially the rate of significant side effects from the immunotherapy drugs, and you can see it's almost tripled from about 5% to 60% with this combination. So we tend to increasingly reserve this more for patients with melanoma brain metastasis, more immunotherapy resistant subtypes like mucosal melanomas, or sometimes patients with very much mutation burden. But something to consider is for those with the desmoplastic histology of melanoma, should we actually consider de-escalating treatment? And now in this era of the combination immunotherapy regimens, perhaps for these patients, maybe just give them the single therapy drug, nivolumab or pembrolizumab alone, if we are already seeing 89% response rate, right, with a single immunotherapy. And the reason for this was the side effect. You see that even going from a single immunotherapy drug to even the nivo or the Opdualag doublet, we see a doubling of toxicity rate as well, from about less than 10% to about 20%. So something to consider. Moving briefly to patients with early stage desmoplastic melanoma, right? So we've been talking about primarily patients with metastatic and stage 4 unresectable melanoma. So what about patients with stage 1, stage 2 desmoplastic melanoma? So the guidelines, again, remain the same as other skin melanomas. The treatment is surgery, right? As we see from NCCN, wide excision, excise the primary tumor, and sentinel lymph node biopsy indicated. But the challenge surgical resection that may be a little more unique to desmoplastic melanoma is, if you recall from these melanomas tend to have deeper infiltration under the skin. They can have perineural invasion. They can make it difficult for a surgeon to have a complete surgical excision, right, and to get clear margins. So sometimes they have to do multiple, very disfiguring surgeries, especially in the head and neck area, right, scalp, face. There can be these very morbid surgeries with large clinical defects. So the question is, if we're seeing such a good response with these immunotherapy drugs in later stage desmoplastic melanoma, is there a role for these drugs in early stage disease to perhaps use them to maybe shrink that early stage melanoma so that maybe the surgery would not be as morbid, it would not be as disfiguring. Exploring the other cohort in this SWOG clinical trial I discussed earlier, where it's with early stage resectable, surgically resectable who were enrolled, right? They essentially, a lot of these were patients with actually stage 2 melanoma, and the criteria was that they didn't receive any prior immunotherapy to enroll. The regimen for these patients, same drug, so one of the anti-PD-1 drugs, pembrolizumab, except this time they only got 3 cycles, right? So the drug, if you're familiar, is given once every 3-week infusions. We got 3 doses, so essentially 9 weeks of treatment, just the 3 cycles, and then they underwent surgery, right? So normally the standard of care would be surgery, but again, for the study, before their surgery, they had 3 doses of immunotherapy drug, and then afterwards were just observed, given clinically, radiographically if indicated. And then if there was any concern for progression, per the protocol, they could have gotten it. So the rationale again was, as we were saying, if this tumor response rate can be so high to immunotherapy drugs in desmoplastic melanoma, if we give the drug prior to surgery and we see significant tumor regression, can the incidence of the more radical surgeries can reduce, can the morbidities from those surgeries be decreased, and can there be essentially higher quality of life for these patients? So there was a total of 29 patients in this study that were enrolled into this pre-surgery immunotherapy cohort of the trial. And you can see almost about 80% had early stage, so stage 1 or stage 2, primarily stage 2 melanoma. Patients with stage 3 were more less common. And we can see here, after the 3 cycles of the pembrolizumab, just the surgeries the patients underwent, so almost all had the wide excision of the primary melanoma, looked at, and then there was one patient we'll talk about who actually thought he had such a good response, he declined to get surgery at all. So what the study was looking at was the pathologic complete response rate. Essentially, after the 3 cycles of immunotherapy, the patients had surgery. What was the surgical response, right? Pathologic response. So this is different than the imaging response, the 89%, all that we were talking about earlier. The pathologic response is basically depending on whether or not there's any viable melanoma in the surgical specimen, right, when the patient undergoes surgery. And a pathologic complete response means there's no viable melanoma left, right? The surgeon operates on where the melanoma is supposed to be under the microscope, no viable cells left. That's pathologic complete response. And in this study, for 29 patients, over half, 55%, pathologic complete response. And none of the patients became inoperable. So of course what you have to worry about is you're delaying surgery with these patients for 9 weeks while giving them immunotherapy. So you want to make sure they're not going from an operable tumor to inoperable, but that was not a concern. All of the patients' melanomas remained operable. And in terms of how this compares, and I see here, I think that the formatting, this number dropped off, but there was another clinical trial done doing the same regimen, 3 cycles pre-surgery immunotherapy, neoadjuvant pembrolizumab, in patients with all skin metastases, primarily with stage 3 melanoma, and this pathologic complete response rate is, I don't think you can see, but the number down here is 38%. So again, just showing this is 55 compared to 38. How the immunotherapy drugs can be in the desmoplastic histology. Looking at now the relapse-free survival, of course, the goal, with patients with earlier stage disease is the surgery, is intended to be curative, right? So afterwards, they're being followed to make sure the melanoma doesn't come back, right? Does not relapse, does not recur. So that's the recurrence-free survival. And essentially, for this trial with the 29 patients, none of the patients to date have yet had a relapse of their melanoma after their surgery. Now, the reason that the curves drop off for here and for overall survival is there were 3 patients who died, but not from melanoma, not from the drug treatment, for other unrelated conditions. So keeping in mind the median age is 75 years old for these patients, so there were 3 who did pass non-cancer related condition. Not from the melanoma. So just a couple figures here, and sorry for the having again. So the patients, so how the desmoplastic melanoma looked at baseline. This is after 3 cycles of pembrolizumab. It's clinically does not look visible anymore. And then this was one patient who had a melanoma on the liver, right? Again, having a great clinical response with those 3 pre-surgery cycles of pembrolizumab, and actually ultimately declined to go to surgery and said, well, why do I need this anymore? So. Now, of course, the side effects, right? So normally the patients stage 1, stage 2 melanoma, typically with surgery being at the primary treatment. We also have to consider the side effects of giving them these immunotherapy drugs, even if for 3 cycles of these drugs, about more in subsequent talks, can have a lot of toxicities, right? So, of course, have to counter that, with using these drugs. So this shows the side effect profile of the pembrolizumab in these 29 patients in the study. And we can see most of the side effects were in more mild, so this grade 1 category, most common being fatigue and rash. And instead of the more severe side effects, like grade 3, 4, was under 10%, right? So a 7% rate. So again, it's certainly possible to have the more severe side effects with immunotherapy drugs, even if you're doing just 3 cycles, right? Unlike our patients' metastatic disease, where we may go up to 2 years. Even with 3 cycles, you can have side effects. But overall, most of these tended to be fairly mild and, side effect profile of immunotherapy drugs. Going back to is one day, would it be possible for some of the patients with these early stage desmoplastic melanomas so clinically respond to immunotherapy drugs if after 3 cycles, over half the patients have no more viable melanoma when the surgeon goes to operate? For some of them, could the surgery be omitted completely, right? And we can't say that just yet, but there is some ongoing conversations within the SWOG committee that conducted this clinical trial of actually exploring patients the possibility of not doing the surgery at all. In summary, the desmoplastic melanoma, again, very rare type, 4% of cases, right? To find out if the person has this, look at the pathology report, especially the primary, and that's where it will be identified. As we've seen in advances, one of the highest response rates to immunotherapy drugs we've seen to date at 89%. So for treatment of advanced metastatic disease, I think we can consider perhaps whether to use a single immunotherapy drug for these patients as opposed to the more toxic combination regimens. I think earlier stage desmoplastic melanoma, I think considering possibly doing this pre-surgery immunotherapy, but I would highlight the importance of what we call this multidisciplinary approach, right? For patients who have surgically resectable melanoma, we have to make sure the oncologists and the surgeons that everyone is talking to each other and is on the same page before doing this, what we call neoadjuvant pre-surgery immunotherapy. Before considering this, and then again, I think further studies may tell us whether they may be a role to possibly de-escalate the surgery or maybe one entirely in some patients with melanoma, but I think to answer that question, we need some data from clinical trials. Happy to take any questions.
just, if you were able to isolate what makes it so responsive, and this might be a dumb question of not how cancer works at all, but would there be a possibility to then either with someone who doesn't have metastatic melanoma, either induce it or imitate it to make it more responsive to immune therapy?
That's a very thought-provoking question. So I guess it would depend on what those factors are. It is primarily due to tumor mutation burden, right? I don't know, we know of a way to be able to induce an increased in other types of melanomas, right? If it's, but if it is something, like tumor microenvironment that we haven't found yet, and we say, okay, desmoplastic melanoma has these features, and can we somehow induce that, with drugs or other treatments and other types of melanomas, right? That could potentially inform us, right? And this is what makes the immunotherapy drug work so well for this rare type. So let's actually try to use that in other melanomas to try to improve the response rate to immunotherapy. Could potentially be possible.
So I want to ask you a question. I want to partially answer Jesse's question. One of the ways to increase the amount of antigens that are shown, that are displayed by tumors, immune system to recognize, is to directly inject tumors with immunomodulatory substances like modified viruses. And I think you're very familiar with that. I want to ask you a question though. Since your other specialty these days, besides dysplastic melanoma, is circulating tumor DNA, and since we don't have a talk about that, I'd like to know as we go on, I've been hearing about a lot of trials where patients who have initial therapy and then they have surgery and there's no tumor cells left, the definition of the path, complete response. Will the circulating tumor DNA test that's available from one or more be used to follow those patients who aren't getting any further therapy to see whether they're having signs of incipient relapse?
Yeah, I think really at times to try to answer that question, we know that following pre-surgery therapy, we see that pathological those patients, regardless of whether or not they get any adjuvant post-surgery immunotherapy, tend to do quite well. But what about those without a pathologic response? And I think there's been, I would say melanoma is the research is lagging a little bit, but that has shown that without a complete path response, whether or not there is detectable circulating tumor DNA, post-surgery can help to further differentiate the risk of relapse. So without a complete path response, if you're not finding detectable circulating tumor DNA that's obtained from plasma samples, I think those patients are still having a better prognosis, less likely to relapse than those with detectable circulating tumor DNA. And I think some of that is starting to be shown in melanoma as well, which of course then is the next question is, can you then do trials based on what you're actually seeing with circulating tumor DNA to actually make treatment decisions based on those levels? I know there's some, a few.
Thank you.
One question. In terms of these, do they get follow-up pembro as well? Like, how long, or are they just off the therapy entirely after? Or after they respond?
In how the clinical trial was done, for the patients with the early stage of dysplastic melanoma, they did not. Right, the way it was just the 3 cycles of pembrolizumab surgery and then observation. Right, they did not receive any adjuvant or post-surgery immunotherapy for the design of that study. Now they were followed closely, right? So at Moffitt, where I work, we actually had a lot of these patients who were enrolled, and they would still come, follow with their dermatologist, which is the rest of your life. But then also seeing us, for scans, physical exams as well, probably about once every 3 months. And then as more time went by, the months became 6 months, became annual. That is an interesting question as we look at, broader context of neoadjuvant or pre-surgery immunotherapy is whether or not to give the immunotherapy after and for which patients. I think that's still an unanswered question because some trials did continue it, right? Not specifically desmoplastic, but just speaking about all melanomas where it was given, and other trials did not give it if the patients had that pathologic complete response. They just stopped and said, I'm just go on to observation.
My second question is though, without surgery, how do you know who has a partial response and who has a complete response?
Correct. So, yeah. So one of the thoughts, in terms of designing a trial, right, with the committee, of trying to see can you potentially limit surgery in some of the patients is could you maybe do a biopsy, 3 cycles of immunotherapy where the melanoma was, because in advanced photographs, imaging, and then if on that biopsy specimen, if you don't see any viable melanoma, could that be used as a marker? All right, and say, well, in that case, let's perhaps watch. Again, that's all in discussion, right? So there's a lot of nuances to it, but that would be one possible way to see would if to watch those patients. Again, that's all, that would be, I think, in the context of a future clinical trial, but I think that's one of the thoughts that was being discussed.
Thank you.
Is your example of, and I'm not sure I can remember the word, is it mesmoplastic?
Desmoplastic.
Yes. What percentage of cases or issues evidence that type? 3% of cases, 20, 50?
4%, yeah, about, so what you're saying, yeah, about 4% of all
4%.
skin, yeah, so definitely.
Doesn't apply to necessarily the 96% that aren't mesmoplastic, is that correct?
Correct. So the desmoplastic histology, right, I think the principles, right, the immunotherapy treatments, as we discussed, are used in all skin melanomas, looking at pre-surgery immunotherapy. I think all that is being looked at in all melanomas. But the desmoplastic type that seems to be very uniquely sensitive to immunotherapy is a rare type. It's about 4%.
For the,
Sorry, David.
good question, I'm interested on the treatment of these patients when they progress, so on the, or not responding, so for the 30% of patients that did not respond in the first study, for the 10% that did not respond in the second study, would it make sense to put a MEK inhibitor, because probably they have an NF1 mutation, or in other words, what is the next step for the non-responders?
We also look at with first-line immunotherapy, but I would say because these were looking at single immunotherapy drugs, for those small groups of patients that doesn't pass it on, better response to immunotherapy drugs. So we have seen in skin melanomas response rate to that ipi-nivo, the Opdivo yogurt combination is about 30% prior first-line immunotherapy. The thought about MEK inhibitors, responses with those tend to be, and MEK inhibitors is about 15%. So my preference, outside of a clinical trial would still be maybe single to go to the doublet, especially that combination in that case. We know more time that it can be effective in first line.
Good question. What about the percentage of those that have desmoplastic versus all melanoma? Like I think I've seen where there's mixed desmoplastic versus melanoma. Like, were those included in the trial or?
Right, so good question. So we didn't get into an interest in the mixed versus the pure desmoplastic, but both our retrospective analysis and the clinical trial did include both the mixed and the pure histology. And we did look separately. It was on that the first waterfall plot I showed. We didn't see a difference in response in the pure versus the mixed desmoplastic histology. So I think we basically treat them as the same.
Are there any studies done with regards to people who decided not to take the immunotherapy that track the incidence of or non-recurrence of those people who decided not to take the immunotherapy, so you can cut to the people who did?
Yes, so the more, so not these trials, these were single, what we call single arm, where all the patients got immunotherapy, but there were studies, so for example, melanoma post-surgery, looking at the efficacy of using immunotherapy drugs to try to, decrease relapse. The comparator of those initial studies was essentially observed. For example, pembrolizumab, there was a large trial, patients with stage 3 melanoma, where half got the active drug, the pembrolizumab, and half got placebo, or essentially observed, if you will, right? And then the data was compared in that clinical trial to the people who got the drug.
Because if indeed the incidence of recurrence was 10% in the people who decided not to take immunotherapy, it would affect my decision to take the immunotherapy and be exposed to the things that you've mentioned in terms of the after effects. If it said 50%, I think much differently.
I will say the likelihood of relapse will change depending on the stage of melanoma, but generally I would think like skin melanoma, just on observation, I would say the risk of relapse is well above 50%, right? It may be.
Is what again?
Is well above 50%. Right, so more likely than not, without preventative treatment, a lot of those patients, their melanoma will come back. That's very different than if someone treat a melanoma, right, where we don't even offer these
Yes.
drugs. So that's where I think that individual decision-making for the state make a treatment plan on how effective, what the underlying risk of relapse is and how much benefit there can be from doing the preventative immunotherapy, right, and whether the risk is worth the possible. Yeah.
Thank you.
Thanks, Dana.
Our next speaker is Dr. Prashant, who is a dermatologist, director of the program at California Pacific Sutter Health in San Francisco. So thanks both for being here. I think we'll try to move along. We'll have to decide about how much of a break.
Yeah, I've revised the agenda a bit. We'll probably finish about 20 minutes later. Break will be 15 minutes, and I think that's all we need.
So,
Unless our speakers want to go quicker. That's another option.
It's a pleasure to be here with you. I was asked to talk about staging, prognosis, but also sprinkle in the little science. So 3 things, and this is a work that we've been doing. I wanted to share some of this work and what motivates us, and why melanomas develop and why they behave more aggressively in some people than others in terms of being able to predict the risk of it spreading. So melanoma susceptibility that we developed, looking at a prognostic factor called mitotic rates. It's been around, it's an old friend, but we've revisited that. And then also trying our prediction, but it better, but in this case, looking at sentinel lymph node biopsy results. So first, starting with susceptibility, why does melanoma develop? And our thinking is that it develops based on a combination of our inherent susceptibility, so certainly how fair we are, eye color, skin color, family history, personal history. There is an inherited susceptibility component that each of us added by exposure to the causative agent, which is ultraviolet or UV light. And this, as has been mentioned, is neoplastic melanoma. Melanoma is characterized by having a lot of sunlight-induced mutations. So when we look at the inherited susceptibility to melanoma, there are certain genes that have identified when you do genetic testing that you can find mutations in these genes. But unfortunately, even when you look at melanoma families where there's just melanoma everywhere, only a minority of these families have mutations in these genes. And so therefore, even when we sit here today, the precise mechanisms that melanoma can develop following light exposure are not completely understood. And specifically, how you can go from sort of an inherited genetic variant, and then take into account sun exposure to get to melanoma development has been unclear. And so this motivated us, and when we were studying a gene called receptor coactivator 3, it's a mouthful, but we'll just look at the gene signal, NCOA3. And it's a member of this family of proteins that what it does is it turns on expression of a lot of growth promoting genes. So it sort of revs up, the cells when it's present at higher levels. And we found this gene when we were fishing, when we were comparing melanomas that had metastasized, that has spread, compared with just primary melanomas. And this gene was highly expressed in the metastatic melanomas. And so we thought, well, if it's higher in the metastasis, maybe it actually is doing something and it's there for a reason. And so then we looked at whether this gene had a prognostic effect. It did. So the more of this gene you have primary melanoma, the higher the risk of the melanoma spreading. But what we really wanted to understand, kind of more at a cellular basic level, was, well, if it's important, how does it really function to melanoma development? And so this, Dr. DeSamir was the first author of the papers in the audience today. So when we first looked at it sort of genetic levels, at the DNA level, we find that this gene is elevated in about a third of melanomas. And when you look at moles, just benign moles, so it does seem like it's a switch that can get turned on, not in all melanomas, but in a certain subset. And then when we block this gene, either by genetic means where you can silence it, or using a drug, a small molecule, we saw that in cell lines, but also in animal models, it could, suppress the growth and the spread of melanoma. And also, as we were doing more kind of cellular analyses, we saw that having more NCOA cells resistant to the, damage of ultraviolet light, to kill these cells would not die when you gave them ultraviolet light. And that made us think, wait a minute, maybe it could actually play a role if it's regulating sensitivity to ultraviolet light. Maybe it actually can play a role in melanoma susceptibility. And we wanted to now look at what we call polymorphisms in this gene. So polymorphisms are thought to be normal variants. So all of us here, if we have a particular gene, we have 30,000 genes in our body, but each one of those genes, when we think of, I have a normal gene, it actually turns out that there are a number of normal variants. And these are called polymorphisms. And so they're not mutations, they just normally occur in the population, but it's possible that these variants can have different effects inside the cell and inside the body. So we wanted to look at this issue of polymorphisms in NCOA3, in our favorite gene, in melanoma susceptibility. And we were kind of assisted by some previous research that showed that morphisms, jumped on me. One of these polymorphisms that's called T960T was already shown to play a role in protecting against breast cancer, in a completely different cancer. So we said, well, variant, and what we took a group in collaboration with University of Utah, where they've collected a lot of polymorphism, was familial melanoma cohort, and if you took a cohort that had no cancer. So it seemed like it's also preventive against the development. And when you look at sort of population-based studies, basically you can see this polymorphism. How often is it present in a European, a Caucasian population, which of course would have a higher risk for melanoma compared with a sub-Saharan African population, and it's really double. So this protective polymorphism is present more commonly in the low-risk populations. Okay. And then when we actually looked at, and David looked at, we had a bunch of cell lines, and we had a lot of tissue specimens that we've collected from patients. that had melanoma, how often do you see this polymorphism there? And it was very rare. It was rare that you would find it. So when there was melanoma, it was rare to find this polymorphism. So why does this happen? And so in other sort of cellular studies that I'm not going to bore you with, but kind of the bottom line is that when you have what we call the normal or the wild type variant, what happens in producing cells that can give rise to, when they get ultraviolet light, the cells don't die, they continue to survive because they have more of this NCOA mutations, okay? So they don't die, they are alive, but they're not normal anymore because they're getting mutations. By contrast, the patient who has the polymorphism, these cells, because it doesn't have as much of the gene expressed, the cells die when they're exposed to ultraviolet light. And that really is a protective mechanism against cancer development. The cell has died, it can't develop into a cancer. So you can imagine that over the lifetime of the susceptible host that has the wild type NCOA3 and continue to get repeated, that can result in the accumulation of mutations that ultimately lets melanoma develop. So now kind of moving to the next category, which is really melanoma staging. Again, this has been alluded to in a number of talks. So, but our staging classification is critical for us having a common language to talk to each other about which are sort of thin or thick melanomas. And so we have the TNM classification in most solid tumors. T stands for the primary tumor, N stands for the lymph nodes, and M stands for metastasis. And I'm just going to focus on the T classification or T category. And this has already been alluded to, but we have 4 T categories, T1, T2, T3, T4. And the breakpoints are based on the tumor thickness that Dr. Bennett talked about. So how thick is the melanoma from top to bottom, the sort of vertical thickness. And the breakpoints are 1 millimeter, 2 millimeters, and 4 millimeters. So the thicker a melanoma is, the higher the risk that it can spread. But then, the thickness alone is inadequate, in terms of really telling us what can happen to an individual patient. So can we refine that prognostic information? And we can. And the one that's been around for 20 years now, well, even more than that, but at least in the staging classification, is this iteration where the evidence is missing, overlying melanoma that can sometimes be signified by a bleeding or sort of oozing tumor. And so the presence of ulceration can result in a higher risk of melanoma spreading. So that has been added to the staging classification. So for every T category, A is you don't have ulceration, B is you do have ulceration. So T1, T2, T3, T4. The one sort of caveat is that in the T1s, we also have this subcategory of if the melanoma is from 0.8 to 1, studies have shown that those patients have a higher risk. So that also makes it a B. But the thing to think about is for every T category, we have an A and a B, A being less aggressive, B being more aggressive. Is there anything else that we can do? So this, to further refine, this sort of prognostic assessment. And so this was a case, actual case of a patient of ours who kind of prompted us to think about this. A 5-year-old gentleman who had a melanoma on the upper back, 1.5 millimeters, without that ulceration feature. So had wide excision and a negative sentinel lymph node biopsy. And when we look at the staging manual and it tells us, okay, this is the T2A, as I mentioned, or a stage 1B, and it spits out a survival, 5-year survival rate, it would be 97% 5-year survival. So we would expect this patient to do incredibly well. And yet, unfortunately, about a year later, this patient had a new cough, and then when did some more testing, there were lung spots on the CT scan, and the biopsy of those showed melanoma. So it had spread in a fairly short order. And when we look at the pathology, it's like, wait a second, what else is there? And we found that there was the mitotic rate for this patient was 7 per millimeter squared. So what does that mean? And so mitotic rate refers to the number of cells that are dividing within a given area of the tumor at the time of the biopsy. Sort of this dark, smudgy thing in the nucleus that tells the pathologist that cell is dividing versus other cells. And so we've gotten into the business of counting these, and it's usually recorded as a number, 1, 2, up to whatever, per millimeter squared, per a given area. And there are many studies for decades showing that, having more mitotic rate, is associated with adverse melanoma prognosis and survival. And in fact, in the previous version of the staging classification, it was included in that T1, that early category, but it got removed in the current classification. And we were not really very happy with that. So we wanted to sort of reanalyze what is it about mitotic rate that we should or shouldn't be thinking about. And mitotic rate is a continuous variable. So what that means is, again, it's a number, right? 0, 1, 2, up to maybe 30 or 40, just like tumor. So when you're analyzing it, how do you really analyze it? And when you have a number like that, identifying a cutoff or cut point to really reflect whether mitotic rate is high or not is absolutely critical. And before we did the study, I had patients coming to me with their pathology report and said, "Doc, I have 3 mitoses. What does that mean?" And I looked at them and said, "Well, I don't really know." And so we had to do the study because not be able to answer the question. Does it seem high? Does it seem low? But not in general, but really for that particular patient. So we published this a couple of years ago, but in collaboration with the Melanoma Institute Australia, or MIA, we put our sort of data together from our institution and theirs, and we had collected 5,000 patients with melanoma that had been followed for almost 10 years, so it's a pretty mature kind of group. And when you look at the whole population of 5,000 patients and statistically look at where are the inflection points, when you look at mitotic rate, where does the survival get worse? We find these kind of cut points, 1, 2, 4, and 7, and 11, that, every time you go to the next level, the survival of the patient gets worse. So that was interesting. But then we said, okay, let's construct an index. So basically take these cut points and look at mitotic rate as if it's these 5 different sort of cut points versus looking at it as a continuous variable, like 0 to 30. So that's the way it's been traditionally kind of looked at. And then you split the group into training and validation. I'm not going to bore you with all of that. But what I'm going to bore you with is this. So, so when we look at kind of the relative impact of prognostic factors, I just want you to focus on the left-hand side. There's something we call the multivariate Cox regression. So you're comparing the impact of different factors on melanoma survival in this case. And so if you look, tumor thickness and ulceration, what we want to look at is this chi-squared value. The higher that value, the more predictive that factor is. Sorry. And so definitely when you look at it, thickness and ulceration are the top 2 factors in this analysis, justifying their incorporation into the staging category. Now, if you look at mitotic rate below that, with the entire scale, so this is as a continuous variable, it really lags behind ulceration. So it makes it look like it's not really that important. It's still significant, but it's less significant than ulceration. But now you go to the right-hand side, and if you really now look at it with those cut points, those 5 cut points that I talked about, now mitotic rate, its chi-squared value, it becomes a little bit higher than ulceration, but really it's almost equal to ulceration in terms of its prognostic significance. So if we do it the right way, it can have a significant prognosis information that is virtually identical to ulceration, at least in this cohort. Now, for mitotic rate to be useful for staging, we have to go back to our T classification. It needs to really refine the survival information within a given key category, because that's the way we stage patients, as I started that discussion. So then we go back to our T categories, T1, T2, T3, T4, and what we want to know is, well, what is considered elevated in each of these groups, like the patient who asked me that question. And what we found, which has not really been shown before, but if you think about it, it may not be very surprising, is that what's considered elevated really depends on your T category. And the higher the T category, the higher the cut point for elevated mitotic rate. So that patient has said to me, Doc, I have 3 mitoses. Well, if they had a T1 tumor, that would be elevated. But if they have anything under that, that is kind of normal for them, in that situation. So then we wanted to compare relative impact of ulceration versus having a high mitotic rate in each of these T categories on melanoma survival. And this is very busy, but I'm going to make it very simple, that you've seen the survival curve. So basically, if you have a higher curve, the survival is better. If you have a lower curve, the survival is worse. And so this is T1, T2, T3, and T4, the 4 T categories. And on the left is if there's ulceration present, and on the right if there's high mitotic rate. And you can see that the difference is almost identical, whether you have ulceration or whether you have mitotic rate. So again, if you look at mitotic rate the right way and you identify useful cut points for it, its prognostic impact can be virtually identical. And so there is a proposal to try to revisit this in the staging classification. And then the last thing I want to sort of end with is another way of trying to predict melanoma outcome, but here we're looking at sentinel lymph node biopsy outcomes. We've heard about having lymph nodes removed. Well, to come here, St. John's and the John Wayne Cancer Institute, where the sentinel lymph node biopsy was really pioneered by Dr. Morton and Dr. Esser and everything. Who am I to talk about sentinel lymph node biopsy? Luckily, I don't do the procedure. Rick should do it. But we're also trying to analyze what's going on. So the technique is clearly revolutionized the way of how we look at whether melanoma has spread to lymph nodes. And most centers tend to recommend this procedure when the risk of a positive melanoma in the lymph node is around 5 to 10%. And when you look at all comers with melanoma in most data sets, about 20% of patients have a positive sentinel lymph node. So that means that the remaining 80% may not have benefited from the procedure other than the knowledge that, hey, it didn't spread. So what motivated us was to thinking, well, if you can have more accurate prediction of sentinel lymph node biopsy results, maybe this could reduce the number of patients that would undergo the procedure, but also increase the number of patients who have positive lymph nodes, resulting ultimately in a more cost-effective selection procedure. So realize that we're not doing anything to the procedure. We're not doing anything to the surgery, nothing to the pathology, but it's just looking at how we really can predict what's going to happen to the patient. And in order to do that, our statistician, Dr. Miller, Jerry Miller, developed a completely new methodology, which I'm not going to bore you with, but it's called patient-centered methodology. And basically what it does is, it's like a statistical Cuisinart. He takes all the different prognostic variables that we have and puts it together in a somewhat unique, and what it spits out is a probability of an outcome. It could be 5-year survival. It could be, in this case, risk of having a positive lymph node. And we had previously shown that if you use this methodology to predict melanoma prognosis, it's actually much more accurate, both in melanoma and breast cancer, if you compared with just using the stage, which is the staging classification that we have. But here we wanted to use this to predict or make individualized predictions of sentinel lymph node biopsy outcomes, and this was published a few months ago. And so again, we turned to our Australian colleagues, and we had our own cohort at CPMC of over 1,000 patients, and they had 3,600 patients that had undergone the procedure, diagnosed over the exact same time frame, and information was available on 12 prognostic factors that we usually look at very carefully. And again, the way that the PCM works, and I'm not going to go into a lot of detail, but I think this is important, that it takes the melanoma population and it splits them into different groups. So it stratifies them, and here it was called low risk, intermediate risk, and high risk. In this case, based on tumor thickness and patient age, which are 2 of the key factors that really predict sentinel lymph node outcome. And then you sort of develop an algorithm that ultimately gives a probability for an individual patient, what is my risk of having a positive lymph node? And then we compared this algorithm with, if we were to just look at these 12 factors in a normal way. It's called multivariate logistic regression. And so to do this, how do you determine accuracy? It's called something that called area under the curve. So basically, you draw a curve of how often can you accurately predict, and if you could, your predictions are perfect 100% of the time, the area under the curve would be 1. So 1 is perfection. Anything below 1 is less than perfection. And the lower you are, the worse you're doing. The closer you get to 1, the better you're doing. So when we go to the Australian cohort, if we just look at the standard way of looking at things, our AUC is around 0.75. So it's kind of like a C, okay? And then when you use PCM to do the same thing, take the same patients, but analyze them in a different way, you can move this up to 0.8. So that now you're starting to talk, because now we're B student now, in that situation. And when we looked at our own cohort, we go from 0.77 to like 0.82. So we can improve by 5 points in terms of our predictions, and this is really the highest AUCs that have been reported to date in the literature. By just analyzing things in a different, we can do a better job of predicting what's going to happen, to the inverse that basically just show, that this improvement essentially, and I'm not going to really bore you with the details of that. But what I did want to share with you, so we talked about the fact that, what we do is to take this whole group of patients and then develop low risk, high risk, and intermediate patients. And now when you look at it, it's that same analysis where you're comparing. What became interesting was that there may be sometimes the same or different factors that are important for different subsets of patients. So if I'm a low-risk patient, it turns out that, the age is critical, the mitotic rate is critical. So you can see kind of the order of how these factors are important, but let's just remember age, mitotic rate, and regression. Now, if we go to the intermediate risk subgroup, something else shows up as number 1, histologic subtype, which includes like desmoplastic melanoma. Regression is still there, but now mitotic rate is lower and age is a lot lower than that. And if you're in the high risk subgroup, interestingly, histologic subtype and regression are still important, but now lymphatic invasion comes up and age comes up a little bit more. So the relative impact of these factors is really different based on, for individual patients, based on whether you're lower. So we cannot and should not be, sort of routinely applying all of these, the same way to different patients when it comes to predicting risk of lymph node positivity. And then lastly, to do this cost effectiveness analysis, we look at 2 measures, as I mentioned before. One is, how many positive lymph nodes have you identified? And the second is, what are the total number of procedures? How many surgeries did you have to do in order to get these positive numbers? So obviously, effectiveness is improved, is increased, if you can identify mutations. So I have 1,000 cases. If I can identify 200 versus 100, well, my effectiveness is better because I was able to identify another 100 patients. Whereas costs, of course, are reduced by performing fewer procedures. So if I could put 500 patients through surgery to find the 200, I'm doing much better than if I had to do 1,000 surgeries, right? So what we found that basically using this technique, it was more cost effective than doing the standard methodology. And this could potentially be used to reduce the number of cases, but also improve the effectiveness of the selection procedure, even though we've done nothing to the surgery, the pathology, and the nuclear medicine. So this to us is an important way of, an important example that we can improve prediction of not just sentinel lymph node biopsy outcome, but potentially many other things. This can improve how we select patients for various procedures, and where we're going with patient. But ultimately, we want to have a web-based tool that already exists for the Australian cohort. But since our mousetrap is a little bit better, a web-based tool that patients can use or doctors to predict their lymph node biopsy results and have that available. So thank you for your attention. Yes.
You were talking about age. Now, Is it better or worse? I mean, is it worse if you're younger or?
Yeah, so that's a very good question. So age has this interesting relationship with melanoma outcome. Now, when we look at survival, increasing age, the older we are, is associated with, a worse prognosis. But when you look at sentinel lymph node biopsy results, the younger the patient is, the higher the risk, of having a lymph node. So there's a dichotomy that we haven't fully been able to explain. Now, it may have to do with the fact that older patients have, don't have maybe as good lymphatic supply because that can sort of go away with age. So that may be one thing. But secondly, there are types like desmoplastic melanoma that was talked about. There are certain subtypes of melanoma that are more prevalent in older patients that just tend not to go to lymph as often as the garden variety type. So there are many factors that can begin, and also, for example, neck melanomas tend not to go to lymph nodes as often as, let's say, trunk or extremity melanomas, and those tend to be more common with, in older patients, a lot of sun exposure. So age has this sort of dual effect depending on what outcome measure you're actually looking at.
Just a couple questions. What's the difference between a polymorphism and a mutation? And can it still be selected for in the population?
A mutation is a change in the DNA pathogenic. That really has a deleterious effect on the function of that protein, either shuts it off or makes it up, whereas the variants in the population, except that some polymorphisms are associated with a differential risk, for certain types of diseases. And that's what prompted us to actually look at it.
Can a population select for a polymorphism?
Well, into all of the, sort of CRISPR things and things of that sort. But technically, I mean, one could, you could test for that in an embryo, for example. Morphism.
Very thought-provoking talk. The older literature's let me go more than melanoma is a different animal, official spreading between those tumor types in your analysis, or you just lump all melanoma together?
Yeah, so the histological subtype, when I assume you're talking about the last part, which is the sentinel lymph node biopsy prediction, or
you got mitotic rates, and then you differentiate between malignant melanoma or melanoma.
Yeah.
You just lump it all melanomas together.
Yeah, so when you look at the subtypes, the Lennox associated with the lower risk, for example, of sentinel lymph positivity. In general, the question becomes, okay, if you have a 4.2 lentic,
your data just to not superficial melanomas, it might be much more of a predictive factor, for instance, than it would be for, and then of course you got the issue that melanoma face, like you suggested, in an older population. I think we take into account also, but I think.
I think we have to look. We haven't done that enough. I mean, this was really all comers and sort of all inclusive. The way the staging classification is, mitotic rate would have an even more stronger impact if you sort of subtract certain melanoma spread with desmoplastic melanoma. Patients who have zero mitosis.
Yeah. It also becomes confusing because pathologists are frequently.
Yes. I'm still a believer in the lens. I'm in agreement.
Yeah. You're a dermatologist.
True, but I think it's a biologic phenomenon that been described that actually for me is very useful. Yes.
Because you've all been so patient
you get a break now, but you only get 10 minutes. Remember the bathrooms and the food and the displays, and come back in 10 minutes, please. And we'll carry on with Dr. Lexi, and we'll try to, make up a little time, like within the airplane, we'll put it out of here a little after lunch. Okay, thank you.
Yeah. Yeah.
Questions you wanted to ask? Oh, okay.
Yeah, I mean, I think as long as, yeah, so then the question, kind of, I think, I think that one is, well, I mean, they're both sort of from an adjuvant therapy. So now, yeah, of course, yeah, I mean, certainly with the prognosis, again, yeah, I mean, I think that right now, if, NCCN or ASCO guidelines, against doing, monitoring, it's not gonna really impact, it's something that we all do, right? So, we're all always but whatever, they're high risk patients. I mean, how do I find them as high risk? I think. Oh, yeah. Yeah. Yeah, it's good to see, right? Sorry, Dr. Everybody. Is it, or is it? Yeah. So only terrible, we did this, consensus, we looked at the data, among other things. Just in general, and so we published that basically just a few months ago in the dermatology journal, but, that basically, the data is not ready for to be really, using this to track. But I think from my category, I mean, I think, the issue is, you have, 3 millimeter deposit in the lymph node. But you know what, that patient should have adjuvant therapy. That's not a regular 3A patient, in that situation. So the point is, you have a rehab, which is adjuvant immunotherapy, so you're looking for more nails, which is, what are, I mean, we've defined them based on AJCC7, AJCC8, but they're high-risk patients that are not sentinel node burden, or whatever.
Yes.
And they have just as high, and we know obviously 2B, 2C has a higher risk than, and stuff like that in terms of relapse risk and survival. So anyway, I think we'll see. I mean, my category was not my favorite prognostic factor, but when they took it out, we were like, oh, we need to reanalyze it because, and really what the AJ did wrong is 0 versus 1. It was the wrong cut, as we showed. The T1, the cut point was 2. It wasn't 0 versus 1. But if you're doing the easiest, yeah. Yes, and I think they did that mainly for ease, like the easiest thing is it there or isn't it? But also the other thing they did was when people do a lot of prognostic analyses of the entire melanoma patients, they look 0 versus 1. So a cutoff that T1 has nothing to do with T2, T3.
Yeah.
Exactly.
so.
They still don't. But the good news is, when it got entered for T, people started coming. And again, we can move all over and stuff, but when you get a
entity that pre-sales all of the things that I needed to do, and Dr. Esser's going to introduce, where's Dr. Lutsky? Sorry, right there, okay. Dr. Lutsky, calling Dr. Lutsky.
You start, you have
All right. It is my great pleasure to introduce my friend and colleague, Dr. Jose Lutsky, who works at Miami Cancer Center. Is that what it's called? Sylvester Cancer Center in Miami. And it has become an expert in melanomas, another unusual beast, and he's going to tell us all about it. Thank you, Dr. Lutsky.
I want to thank Dr. Margolin and Dr. Esmer for that invitation.
You have to speak loud enough, but the mic really only speaks to the screening, and then, yeah.
See, what I'm seeing here is, move forward. Okay, so the question is uveal melanoma in suspense. Yes, it is. Similar to Errol mentioned, it's a 4% also type of melanoma. And by the way, I want to thank Dr. Errol for deconvoluting the medical oncology jargon that I'm going to be using here. So it saved me a lot of time. We'll be able to catch up just because of that. Thank you. So melanoma used to be called the malignancy that gives cancer a bad name, and because the outcomes were terrible, and somebody actually said that it became known as malignancy that gives cancer a bad name, but that has changed. Melanoma actually created a new kind in cancer treatment, added the fourth pillar of cancer treatment, which is the pillars of cancer treatment: surgery, radiation, chemotherapy, and now immunotherapy. This is the landscape of melanoma treatment, and you can see all of these drugs that have been approved for the treatment of melanoma over time. And you can see on the left, in the 1980s there, I made it a little darker because that was the dark era of melanoma, where we really suffered. We couldn't really do much. We couldn't really cure many patients or even treat them. The drugs that were available were toxic and mostly ineffective. But since 2011, when ipilimumab was the first immunotherapy approved, we've made tremendous success. And this is one of my first patients that was on pivotal clinical trial of ipilimumab. And this was a 3-year-old. She was a singer from Venezuela, and she was pregnant with her second child, and she developed melanoma on the chest wall. We waited until she delivered. She delivered a few weeks later, a little early. But by the time we were able to scan her, she had widespread metastatic disease, as is noted on the PET scan. All the dark spots, with few exceptions, are metastatic lesions. And she received conventional treatment, did not respond, and she was put on this trial in which some patients received the vaccine alone, and some patients received the same vaccine plus ipilimumab, which was drugs. And surprisingly, or I guess not so surprisingly, in these cycles, all the lesions disappear. And you see here it says March 2018. She's still alive and taking no recurrent disease, dealing with her adolescent kids now. So this gives you a more broad spectrum of what's happened over the years. And this shows, if you already understand, the higher curves are better. It shows how the survival curves went from a survival rate of 5% to a survival rate of 50% just in the last decade, using immunotherapy and targeted therapy. Now, what's the difference? So targeted therapy interferes with the tumor's growth pathway. So in melanoma specifically, we know that about half of the melanomas have a specific mutation that drives the growth of the tumor. And there are drugs now that can interrupt that. And so it's been very important in treating these patients with metastatic disease. Any immunotherapy mobilizes the immune system to kill the tumor cells. So that's the difference. So here we have our Nobel laureate having a brainstorming scientific session in discovering melanoma. And I'm sorry that this didn't come out very good. Let's see if I can get rid of this here. I don't think I can even move this out of the way. Anyway, this man is Jim Allison, who received the Nobel Prize for discovering the pathway that led to all the immunotherapy discovery. So you can see his other passion is harmonica playing. So. Okay, am I on white screen again?
So full screen?
You're on full screen.
I'm sorry. Yeah, I'll just move them. No, maybe the presentation's not there.
This is your
Yeah. I know, it really does. Much for catching up.
We could turn you up to 1.5 speed, like you do on the, when you're listening to the podcast.
Okay. Oh, there you go. That's the one I want to show before the slides. So these are those that really, this is what you're supposed to see after that. Let's move on to the next one. So when you get to uveal melanoma, you see a very different curve. You can see the progression-free survival, overall survival curves there. You can see that these are markedly worse. Median overall survival was just about 10 months. And this is looking at 912 patients, which is a lot, being a rare disease. So it is a different disease. The incidence is different. It's 4% of all melanomas. Is much less common. The cause is different. We know that cutaneous melanomas are, for the most part, related to exposure to ultraviolet radiation. Uveal that the types of mutations that we see in uveal melanoma are very, very different from cutaneous melanomas. And uveal melanomas, they all have specific mutations that occur over and over again, and these mutations, you find we don't see a lot of because, as was mentioned before, mutations, these tumors tend to be more likely to respond. It's not the case with uveal melanoma. The management is different. The way we treat uveal melanoma, we treat the primary tumor usually with radiation or enucleation, taking out the eye, depending on how advanced it is. And the way the prognosis is different. We don't do sentinel lymph node biopsies for uveal melanoma, but there are a number of methods, and in the US, the method that we use the most is what's called a gene expression profile, in which with a fine needle biopsy of the lesion, we're able to tell which patients are destined to recur and patients that are not. The metastatic presentation is different. We know that for cutaneous melanoma, it goes usually the skin to the lymph node to the other organs. In uveal melanoma, I don't think anyone here would guess the first place where it goes to, right? It's the liver. It goes to the liver, unclear. There are factors in the liver that predispose to nesting and growing there, but it usually goes to the liver 80% of the time. First presentation of metastatic disease is in the liver, and about 50% of the time it's the only place where it goes to. And then the treatment. We have lots of treatments for cutaneous melanoma. We just actually acquired one approved treatment for uveal melanoma just recently, just about a year and a half. So it's about 2,000 new cases a year in the US, about 8,000 globally. What are the risk factors? People that have nevi in the back of the eye, people that have melanocytosis, which is usually around the eye, the sclera. I'll show you some examples of that. Patients that have a familial mutation involving a gene called BAP1 and some NF1 mutations that were mentioned early also have been associated with uveal melanoma. Patients that have a dysplastic nevus syndrome, which is funny-looking balls all over the body, predisposes them to melanoma. It's a much higher risk in Caucasians, older people, light eyes have a higher risk. However, sun exposure does not seem to impart a higher risk on these patients. And as mentioned, about half the patients that walk in the door will eventually develop metastasis. And that's why it's very useful to find out which ones are the ones that you need to focus on after the primary treatment. So you see about 90% of these melanomas are in the back of the eye, the retina, or the choroid, 8% are in 4% and so on the left, you see the melanosis of the sclera, so that's a risk factor. The dysplastic nevus syndrome in the middle. On the upper right, you see a mole in the back of the eye, which is a predisposing factor. Those need to be watched closely. What are the treatment options? So the treatment options for the primary tumor, for the eye tumor, the ones that we most commonly use are plaque brachytherapy, and more recently, a little bit more for proton therapy and enucleation. If the tumor is if the patient has already lost vision in the eye, the best way to proceed is to enucleate the eye, to take it out. But patients that have potentially salvageable vision, those patients we're going to treat with plaque brachytherapy. And it is a here, and there's a plaque attached right next to it, and that plaque, radioactive seeds in it, and you leave that plaque on usually for 3 days in the hospital. You take it out, patients go home. And that is actually very, very effective in controlling the primary tumor. So what's next after the treatment of the primary tumor? Then you know that some patients will develop recurrence. You know, just walking in the door, 50% will develop recurrence, right? And that's where, what I told you, there are different ways. There's the standard staging system, which uses clinical information, size of the tumor, the depth of the tumor. There are also TCGA-based staging systems that use a genetic and so a combination of both, this LUMPO system. Report. If you're class 1 praying negative, it's an excellent program. If you're class 1 praying positive, it's still very good, but not as good as praying negative. And those patients have metastasis late, sometimes 10 years later, which actually has an impact to less monitoring in the beginning and more monitoring at the end, which is not usually the way we do things. And if you're class 2 praying negative, you have a high risk. If you're class 2 praying positive, you have super high risk. So knowing this helps us to define how we're going to treat it, how we're going to follow these patients. And for low risk, we're going to do scans less frequently. We're going to see them less frequently. If they're intermediate risk, we're going to do a little more. If they're high risk, we're going to do more intensive surveillance. It also helps us define the population that should be getting the treatment, right? So the patients that are high risk, maybe we want to treat those patients to prevent a recurrence. So I told you that most patients will present with liver metastasis, and many of them just with liver metastasis. And because of that, there have been a lot of treatments directed. And here's just a list of all these treatments. They usually involve going into the hepatic artery that feeds the tumors in the liver, and then you can, put a little gel foam material that's going to be arteries and kill the tumor by starving the tumor of blood supply. Or you can do that and throw in some immunologic agents like GM-CSF. Or you can do that and add some chemotherapy. Or you can do that in a method that's actually used a lot, using some radioactive microspheres of yttrium and that actually happens to be a very this method seems to work very well. You can also do a surgical resection if it's limited, but as Dr. Essner will tell you here, very often, unfortunately, when you go in to do a surgical resection, a lot is found in these patients than you can see on the scans. So we don't do a lot of that except for very selected cases. And you can do ablations. If you have just isolated small lesions, you can cook it, you can freeze it, you can use radiofrequency ablation, or you can use radiation therapy, localized radiation therapy. More recently, also, there have been a perfusion of our liver with high doses of chemotherapy with systems that prevent that chemotherapy from going throughout the rest of the body and preventing the side effects of that high doses cause. And just recently, one of these systems was approved. It's a catheter that can be put in through the interventional radiologist. So previous ways to do this, surgical intervention, big operation, to get into the circulation of the liver. It's not a picnic, but it's a lot simpler, and patients can go in a hospital later. And this has shown for the right patient. So just for this, should have disease most, it should not involve more than 50% of the liver, because otherwise, you're going to be killing a lot of good or possibly very critical liver cells. Let's go to immunotherapy. You saw the wonderful responses that we had in cutaneous melanoma. So, and in the red square, you see the types of responses that we see in uveal melanoma with the same sorts of agents that have markedly good responses in cutaneous. That was appointment. This is another trial. This is probably the best number that we have in uveal melanoma is this 18% response from the Anderson group. The survival is not really well defined. We're not really sure that this actually helps patients very much. At Sylvester, we see a lot of uveal melanoma. We see between 180 and 200 new uveal melanoma patients a year. So remember, there are 2,000 in the country, so we see about almost 10% of the cases in the US. And Dr. Bill Harbour, that used to run the ocular oncology service at Sylvester, looked at a number of, and he has a huge collection of samples from these fine needle aspirations. And one of the things that was found in his lab is that the melanomas have a high expression of this checkpoint called LAG3 that was alluded to in one of the earlier talks. And that had never been shown before. And because of that, we started a trial in which we used an inhibitor, and decided the partial results of the trial that was presented last year. We have already completed the trial at this point. This was data for 20 patients. We have the full cohort of 27 patients treated, but the results did not change much. Unfortunately, we got only about 10% of these patients. 25% of patients, there was stabilization of the disease. In this disease, stabilization is better than progression. So we have what we call a clinical benefit of around 45%. So it wasn't a home run, but the one that we got these patients before and after treatment, and we're able to find, using these correlative studies, clues that might direct us to what kinds of pathways are making these cells resistant to the immunotherapy treatment. So here are reasons why these treatments fail, and specifically in uveal melanoma, we think that one of the problems is the T cells, which are the warriors of the immune system that kill the tumors. They do not infiltrate these tumors. They don't get inside the tumors to kill them. Maybe they have not been primed enough, which is a process that occurs when you want to sensitize T cells. Also, there are few neoantigens because there aren't a lot of mutations in these tumors. And here, just to show you the types of tumors that respond respond to immunotherapy are the ones that are called inflamed. And you see on the left there, the dark staining cells are the T cells, and they're in the tumor, and most likely will respond to immunotherapy. But when you look at the one in the middle, the T cells are free of the tumor, they're not getting into the tumor. Or it could be even worse, there are no T cells at all in the tumor. So these are called immune deserts. So these, this is what happens with uveal melanoma. So those two types. And here is just another piece of data that shows that the tumor mutation burden in uveal melanomas on the left is a lot lower than in cutaneous melanoma. We already discussed that seems to correlate with response to immunotherapy. But there are some avenues to pursue around that. We can try to stimulate the tumor microenvironment, and this is one of the ways to do that. There's something called toll-like receptors that are part of the system that recognizes bacteria and viruses in humans that stimulates the immune system that way. So some drugs actually stimulate that innate immune system, and maybe that will make these uveal melanomas more sensitive. And this is one such drug, and there is an ongoing clinical trial that's using this drug to stimulate the innate immune system in conventional immunotherapy in uveal melanoma. The drug is given inside the liver, is given through a hepatic artery infusion, and we're seeing some early good results with that. Some of the data is going to be presented actually next week in the big immunotherapy meeting in San Diego. So this is just one example. Now, getting back to the home run, or well, for uveal melanoma, it's a home run. This is the molecule called tebentafusp. So this was created to bring T cells to the uveal melanoma cells. So as you can see here, the top end has very affinity for whatever you want to make it to have high affinity for. In this particular case, it has high affinity for a protein called GP100, which, as you can see on the right-hand side, is very, very prevalent in both cutaneous and uveal melanoma. So that portion of this molecule attaches to the uveal melanoma cells, and the other end is like that, waiting for T cells to come by, and when they do, they attach the T cell. So what happens is what is shown here. The one portion attaches to the GP100, which is the green there, and then as the T cells pass by, they get attached to this molecule, and then the T cells are activated and kill the tumor. That's the idea. So this is called a T cell redirector, which is a pretty nice descriptive name. So this was the first positive phase 3 study in uveal melanoma. All the other previous studies in uveal melanoma have been negative. So here patients were randomized to either receive the new drug, this tebentafusp, or to receive an investigator choice within 3 different options. Let me also make a note here that not everyone is a candidate for that drug. The expression of this GP100 protein requires a specific type of immune system that you're born with. You can't acquire it. You either have it or you don't have it. It's called the HLA-A201 subtype, and you can test that with simple blood tests. About 40% of the population are HLA-A201 positive, depending exactly where you are in the different ethnic distribution of where you are. But these are the results. So there was an obvious survival benefit for the patients that received the tebentafusp. And we did not have 3-year data. These were just presented actually last week. So you're getting hot off the press data here. But in the first year, there was a 72 versus 60% survival. for the patients that received and didn't receive the tebentafusp, 49 versus 30, and at year 3, 27% versus 19. We don't know if this curve is going to flatten. We probably have to wait a little longer, but either way, it has clearly prolonged the lives of some of the people that benefited from it. And in 46% of the patients that received the tebentafusp, there was control of the disease. Remember, control means responses plus stable disease. Compared to 27% of the patients, they got just investigative choice. So this drug also has some peculiarities. When you give it, it has to be given weekly, okay, which is not particularly comfortable, but that's what we have. It's a weekly infusion, and the first 3 infusions need to be done in the hospital. Why? Because there are severe side effects that can occur in the first 3 infusions. They're called cytokine release syndrome, but they're manageable, and patients usually go in, they're observed overnight, and then they leave the next day. And sort of magically, after the 3rd or 4th infusion, these side effects tend to disappear. And this is what this is showing. In the beginning, there's those high adverse events, and then as it goes, you really don't have an issue with side effects. Another thing that has been tried in these patients is cell therapy. You all know about cell therapy, or TILs, tumor-infiltrating lymphocytes, from cutaneous melanoma, and TILs are going to become standard of care probably in the first quarter of next year. And what is the principle there? The thing is that you look at the tumor, it has the T cells there, but it's not dying. Why is it not dying? We think there may be other cells there that are preventing the TILs from killing the tumor. So the idea here is to take a piece of the tumor, surgically pull out the TILs, the tumor-infiltrating lymphocytes, grow them outside of the body, and then when you have enough of them, you want to give chemotherapy to the patient to knock out all the bad immune cells that are in the tumor, and then give back the TILs. And when you do that, and there have been a number of trials that have looked at that, there is a 35 to 40% durable response rate. And these are patients that have received prior immunotherapy. So it's legitimate treatment, not a pigment. It requires hospitalization. There are a number of side effects, or they're brief. And most likely, as I said, will become FDA approved next year. Now, here they try to do that with uveal melanoma. So this is a very small group of about 20 patients, and there were some patients that appear to have responded. So more work needs to be done there. There's another trial ongoing for these patients at the University of Pittsburgh, and we want to see what's going to happen there. Another way is to take the T cells from the patient's circulation and change them, make them target the tumors. And this is one way, we're doing a trial like this in which patients with uveal melanoma who have PRAME, which is an antigen that's prevalent in uveal melanoma, in their tumor, they have their T cells taken out of the body. The T cells are modified to target PRAME, and then these T cells, again, after chemotherapy to knock out the bad cells, these T cells are reinfused in the patients. And the advantage of this particular method is that you don't need surgery. You use the peripheral T cells from your blood. The disadvantage is we don't have enough data, and we have a lot of data with TILs. So this is showing that in the red arrow there, patient with uveal melanoma, they had a very marked regression when treated with this. So this is very early results of this trial. We still have to see what's going to happen with this, but it's encouraging that we're seeing more and more cell therapies being used in uveal melanoma. So we didn't talk about targeted therapy again and uveal melanoma. And the reason is that it's not that we don't know what the pathways are. You can see that we kind of know what the pathways are, and we've tried to interrupt this pathways in a number of ways. We, as the scientific community, again, unfortunately, as you can see that pretty much all of these trials have not been home runs. Responses are low, and duration of responses have been very short. However, very recently, there has been a new drug or combination of drugs that have targeted both these pathways, the PKC and the CMAP pathway. And turns out that when you inhibit both of those pathways, it's lethal to the cell. It's called synthetic lethality. And when you do that, you actually end up having these kinds of results in patients with uveal melanoma. Response rates of 30% were previously unheard of with in uveal melanoma. And you can see that only a small percentage of patients on the left actually had growth of the disease. So these very encouraging results that led to a randomized trial that has just recently started, and it has two phases. The first phase will try to find the best dose for the combination, and then it will go on to a standard phase 3, in which half the patients will receive the new combination, and the other half of the patients will receive whatever standard of care is available. And patients that are HLA-A201 positive will not be eligible because they are going to get benefits, which is the first line. Okay. So here we go again. How do we find that one person that is at high risk? So there have been a number of adjuvant, and adjuvant, now means preventative trials in uveal melanoma. And, when you see a lot of studies, it means that none of them has actually worked very well. None of them are definitive, and that's certainly the case here. There's been a number of studies using different approaches to try to decrease the rate of recurrence of uveal melanoma. And unfortunately, I don't have a lot to report here. There are studies currently being planned. For example, there's an adjuvant study with bempifusp in, again, patients who are HLA-A201 positive that should start, within the next several months. And here there's a neoadjuvant study with the new drug, this darovasertib, that I just mentioned to you, that works very well in metastatic disease. So here it turns out that some investigators in Australia decided to treat patients with this drug, one drug alone, before they had their definitive surgery or radiation. And it turns out that a good number of those patients, their primary tumors shrank. So with the basis on that, this neoadjuvant study has been done. We just actually this week, and we have our first patient. And here, what we want to do is, there are two groups of patients. The patients are going to have enucleation because the tumors are too big, but they still have some vision. And the patients that are going to get a plaque. So those patients are treated with this drug for 6 weeks, and then we look again. If there's shrinkage, then the patients continue their treatment after their treatment. But the idea here is, one, you may be able to avoid enucleation in the patients, then they still benefit from the treatment. And those patients, maybe the tumor will shrink enough that now you can use plaque radiation. And in the second group, you may be able to give less radiation to the patients that with pairs. So that's a very exciting study, and with Dr. Zedek, who's our ocular oncologist there. And we have our own homegrown adjuvant therapy, and that's based on the data that was generated by Dr. Harvard's and Dr. Correa's lab from our ocular oncology department. And this is an epigenetic drug. So that means that this is a drug that by a very long process, a high throughput selection, to inhibit, to reverse the effects of loss of BAP1. I mentioned to you before that BAP1 is one of the genes that is lost in patients that have very high risk of recurrence. So this drug appears to imitate the results, the effects of BAP1. And when you use this drug, all the characteristics of less aggressive tumor seem to come back to the tumor. So here you can just see, it's very easy just to look at the bottom. These are uveal melanoma tumors from mice xenografts, and you can see and on the top and the bottom. The bottom is controlled, the top are the patients that are treated with this drug. It's an oral medication. The last one, that is a cell line it's a tumor that does not have BAP1. So it's very specific for patients that have this BAP1 mutations, which turn out to be all the high-risk patients, okay? So we are going to get this started either towards the end of this year or the beginning of next year. We have 11 institutions that are going to be participating on this. Will be 60 patients that will be receiving this. So we're going to be doing a lot of correlative studies, and whatever happens, whether it works or it doesn't work, we need to understand why. So we have a number of other trials for uveal melanoma. Sylvester, as I mentioned, we see a lot of these patients. And my last message here is that this is a potentially fatal disease, but we have to take a walk in. It has been in the past understudied and underfunded. And I think that's no longer the case. I think there's a lot of attention to this disease now. And we now do insights in the molecular and immunobiology of the stuff. We can do more. There's a new trials, we do talk, and there is light at the end of the tunnel here. So, and also I'd like to acknowledge other people I work with at the Cancer Center, and particularly our Detainers Oncology Group and Dr. Ann Harbour's lab. Okay, thank you.
I think we should probably move on, yeah. We'll have opportunities at the end, I think, to ask the question.
Can I just say really quick, Dr. Lutsky is my mom's oncologist. She is 100% alive with us today because of him, and so, yeah, we appreciate everything about it.
My pleasure. You have to, because I am of it.
Next, Denver. Okay, I'm gonna. So, David is dealing, I'm gonna introduce my dear friend and Nurse Mary, now Dr. Mary Carroll from the City of Hope, who knows how to do everything related to oncology, administration of nurse, and she's going to tell us about, she's going to tell us about recognizing and managing some of the most important IRAEs, what's known as toxicities from immunotherapy.
Introduce yourself.
Hi, Mary. I'm never before, and like,
Oh my God.
MO got lost twice getting here, even though I have backs on. But it seems very nice. I've been in California for 38 years, and Santa Monica.
Wow. Oh, Mary.
Too busy working. Therapy has its own side is different than the chemotherapy side effects. And sometimes they can be severe. But I think the most important thing to remember is that the side effects can be manageable if we know about them soon enough. So we rely on our patients to tell us how they are doing. Yes, we can look at your labs, yes, we can look at scans, but we don't know what's happening day to day at home. And we'll go over that a little bit more as soon as they can find it. It's there, isn't it? And I'm going to try and make up some time. There's a couple things, a couple subjects in my presentation that are not very common that I will not go over in order to get things moving a little bit.
Yeah, and we can always talk about them after if people have specific questions. I don't want anybody to go home feeling like they didn't get their questions answered. But no matter how well you know Mary, she will not give you the recipe for the Christmas cookies. So don't even think about it.
Actually, I just went and bought my 50 pounds of chocolate.
Did you?
Use this to advance. Click through. Changes, and you might have to click through as well.
Okay, so why do immune adverse events occur? This is very simplistic. Immune checkpoint inhibitors release a natural brake on the immune system, which causes an increase in the T lymphocyte activity. It's like, come on, T lymphocytes, let's get out there, seek and destroy, a job that you failed to do to begin with. This can cause immune-mediated inflammation of any organ system. While we want the T cells to go and get the cancer cells, we don't want them to go get other tissues, but unfortunately that does happen. So organ systems that can be affected, the cutaneous, musculoskeletal, cardiovascular, GI, neurologic, pulmonary, and renal. So this is a really nice little graph here showing the adverse events overview, the duration, the toxicity grade. So if you look at the light pink, in fact, I'm going to do what the other doctor did. This is our skin toxicity right here, showing it starts just before, it can start just before week 4, peaks around week 5, kind of ends around week 6 or so. Colitis, look at colitis, starting a little bit after week 4, big curve up there, and lasts for quite a while until week 10. And then over here we have nephritis, and this is the one I'm not going to speak to, not showing up to maybe week 20, peaking a little bit before week 30. Although I take this with a grain of salt. I have seen nephritis happen at week 4. I have seen colitis not happen until week 12. Okay, so everyone is different. So the systems I'm going to talk about today will be cutaneous and the rashes, GI with colitis and hepatitis, and pulmonary. I am not going to include renal at this time. Cutaneous, here's some pictures. We have a general rash, maculopapular rash on the left, typically what we will see. But then we can also see the psoriasis and the palmoplantar pustulosis. Please don't be sitting at home with your feet looking like this. Okay, please tell us. Cutaneous toxicities, including rash, itching, vitiligo, are the most toxicities, reported up to 71 patients receiving immunotherapy treatment. We're going to talk about each treatment in relation to its grade. So a grade 1 is a rash less than 10% of the BSA, body surface area, with or without itching. We'll continue the treatment. We'll use topical emollients. We may use a mild or moderate topical steroid cream. Important for patients, avoid hot showers, avoid prolonged showers, use mild soaps if any. Use emollients without fragrance because fragrance has alcohol. That's what makes them smell so pretty. When you have alcohol, you have more drying of the skin. Stay out of the sun. Grade 2, we have a rash that's 10 to 30% of our body surface area. We may have or may not have symptoms of itching, burning, tightness. It may prevent us from doing our normal daily living. Holding and monitor weekly how you're doing. If you're not improved over 4 weeks, we're going to call this a grade 3, and I'll show you how we'll treat that. But going back to grade 2, we'll again treat with the topical emollients, oral antihistamines for itching, and again, we'll use some topical steroid cream. We may consider starting prednisone, okay? And we'll start low, 0.5 to 1 milligram per kilogram, and then we're gonna start tapering this over 4 weeks. So what's happening is we've overstimulated our immune system. It's showing us that by giving us this rash. We kind of need to slow it down, we need to settle it down, and that's where prednisone comes in. For each of the issues that I speak to today, prednisone is our friend. If itching without rash, we can consider topical remedies such as refrigerated menthol, which is carried at CVS, and pramoxine lotion. I actually went to buy pramoxine lotion because I chose to buy, and there's 2 kinds. There is regular and there is sensitive skin. Only the sensitive skin has the pramoxine in it. The regular only has the refrigerated menthol. So important to know. For grade 3, we have a rash that's greater than 30% of our body surface area. We're going to hold treatment at this point. We're going to consult with dermatology. Again, treating with topical steroids. We may use phototherapy for severe itching, oral antihistamines for itching. We're going to definitely at this point initiate oral prednisone, 1 milligram per kilogram, and we'll taper that over 4 weeks. What do I mean by taper? Meaning as each week goes by, we'll decrease the dose. When the symptoms are less than or equal to a grade 1 and prednisone or the equivalent is below 10 milligrams per day, we may consider resuming with close monitoring and following up with dermatology. Itching without rash can be treated with certain drugs, gabapentin, pregabalin. Grade 4, we have severe consequences requiring hospitalization or urgent intervention. If we haven't already, we're going to hold treatment. We're going to admit you to the hospital, consult with dermatology. We'll start you on IV steroids at this slow taper when the toxicity resolve, and then transition over to oral. We may at this point consider alternative anti-neoplastic therapy over resumed therapy if the skin toxicity does not resolve to less than or equal to a grade 1. If immunotherapy is the only option, we will consider restarting once the side effects have resolved, and we'll have very close follow-up with dermatology. Gastrointestinal toxicities, colitis. You can see on the picture, this is a PET CT of a patient on immunotherapy for about 3.5 months. Came in, presented with bloody diarrhea 7 or 8 times. And the PET scan for number A, you can see that's the descending colon that's lighting up and showing inflammation. B and C are also showing some fat stranding, showing some inflammation. You can see on C the bright lighted areas where the arrows are. Inflammation. And we're going to look at this picture again. The frequency of colitis in the literature ranges from 8 to 27%. Incidence of diarrhea is as high as 54% in patients receiving the anti-CTLA-4 antibodies, especially in patients receiving both the anti-CTLA-4 and the PD-L1 in combination. And it talks about toxicity less common with monotherapy. I don't agree with that. We see a lot of diarrhea, we see a lot of colitis on monotherapy. What's really important is we need to work up the diarrhea first. We have to rule out, is it infectious? Is it viral? We have C. diff. What other causes could be causing that? So they may be doing some certain fecal tests. You're going to be asked to poop in a cup, and it's going to go to the lab. So grade 1 is an increase of less than 4 stools per day over your baseline. Some people say, oh, I normally have 4 stools a day. Okay, then that's not considered a toxicity if you show up to clinic and you're having 4 a day. Or mild increase in ostomy output. We'll continue immunotherapy, or we may hold temporarily and resume if we see the diarrhea is not getting any worse. Supportive care can be given with loperamide or Imodium. only if infection has been ruled out and without any colitis-related symptoms as a temporary measure. Monitor the patient every 3 days. We'll be calling you until stabilized. Important to maintain hydration. Watch your diet. This isn't the time to be eating, the spiciest Mexican food you can find. If prolonged grade 1, obtain a GI consult, possibly having endoscopies. For grade 2, you have an increase now of 4 to 6 stools per day over baseline, moderate increase in ostomy output. We're going to hold treatment at least until recovered to a grade 1. We may include supportive care again with Imodium if infection has been ruled out. Consider a consult with GI. And we may be administering steroids, 1 milligram per kilogram per day of prednisone or the equivalent until symptoms improve to grade 1. Then we'll start our taper over 4 to 6 weeks. We also may send you to the GI doctor for an endoscopic evaluation. We may consider the addition of anti-tumor necrosis factor infliximab or vedolizumab antibody when colitis is steroid refractory. That means 3 days later, we see no change. There are other medications that I'll go to talk to at the end of the presentation. We may, after symptoms improve to less than or equal to grade 1, when the steroid taper is completed. Risk and benefits review, have to talk about that with the patient. There's other ways we can review that also with some of the fecal studies. Grade 3, we have an increase of greater than 7 stools per day over baseline. This is getting a little bit more complicated at this point. So we're going to follow all the grade 2 recommendations. We're going to consider hospitalization because now we have the possibility of dehydration, we have electrolyte imbalance. We're going to administer steroids, again, 1 to 2 milligrams per kilogram per day until symptoms improve. Then we're going to start to taper over 4 to 6 weeks. We may consider giving you IV steroids also. At this point, we're also going to consider early introduction, again, of infliximab or vedolizumab in addition to the steroids with the high-risk endoscopic features or where we did not have a response to the steroids in 3 days. Grade 4 is life-threatening consequences. We're going to follow grade 2, grade 3 recommendations. We're going to permanently discontinue treatment. We're going to provide inpatient care. We're going to administer IV steroids until improve again until grade 1, and then we'll start to taper over 4 to 6 weeks and transition over to oral. We may consider again early the biologic additions, and we may consider lower GI endoscopy if symptoms are refractory despite treatment and there's a concern for new infections. So here's our picture again. This is pre and post treatment with steroids. Look at the difference between A and D. We no longer see that line of a descending colon. We no longer see in section C the bright lights. So it works. Okay, again, it's manageable. Let's talk about hepatitis. Probably the first sign of hepatitis that a patient will see is that their eyes are yellow. We'll be watching your labs all along, but the first thing that you're going to notice is that yellow glow. Hepatotoxicity has been reported in 2 to 10% in monotherapies, 25 to 30% for all grade hepatitis with a combination, and approximately 15% incidence of all grade 3 toxicities. Grade 1 is asymptomatic. Your liver function tests are within normal limits to 3 times upper limit, total bili upper limit to 1.5 times the upper limit. We'll continue treatment. We'll think about what else could be causing this. We'll consider monitoring labs 1 to 2 times a week. Really important to find out and to make sure that patients are not taking all of these different kinds of cleanses you can get on the internet. The liver cleanses or liver pills or keep your liver clean to your liver and can just contribute to the toxicity. Grade 2, again, asymptomatic. Liver function tests are now 3 to 5 times upper limit of norm. Total bili 1.5 to 3 times upper limit of norm. We'll temporarily hold treatment. We'll review and discontinue any unnecessary medications and any known hepatotoxic drugs and oncologic agents. We may start steroids if no improvement is seen after 3 days of holding treatment. We'll monitor labs every 3 days, and if we still don't see any improvement, if after holding it we don't see any change, then we're going to add the steroids. At that point, we'll monitor every 3 days. If we're not seeing improvement, we're going to consider another medication that can help calm down the immune system, mycophenolate mofetil. We'll taper steroids when symptoms improve to less than grade 1 and resume treatment when steroids are less safe. We'll also consider a hepatology consult. So for grade 3, we have AST, ALT, those are your liver enzymes, now 5 to 20 times the upper limit of norm. Total billing, 3 to 10 times upper limit of norm. And now you're symptomatic, but typically you're symptomatic by this time. We'll follow grade 2 recommendations. We're going to permanently discontinue treatment if asymptomatic. We'll consider stopping treatment if you're asymptomatic. If you're symptomatic, it's a done deal. Treatment will discontinue. We'll start steroids 1 to 2 milligrams per kilogram or equivalent of prednisone. And steroid refractory, we're going to consider a biopsy to rule out any other causes. Could it be NASH? Could it be a different tumor? Could it be another autoimmune entity? Could it be drug-related toxicity? A different drug-related toxicity. If infections work, we may consider adding azathioprine or mycophenolate. We'll have labs daily or every other day. If no improvement, we're going to refer you to the hepatologist for further pathologic evaluation. That means you'll need a biopsy. Steroid taper can be attempted around 4 to 6 weeks when less than a grade 1, and we may need to re-escalate steroids. So we've had patients that 6, 7 weeks, we get them down to almost normal. We stop the steroids, and 2 weeks later, boom, their numbers are back up, and we have to restart the steroid. Optimal steroid duration for hepatitis is really unclear. Grade 4, we have your liver function test greater than 20 times the upper limit, and total billing 10, greater than 10 the upper limit, decompensated liver function. We're going to follow grade 3 recommendations, and we're going to be administering the steroids by IV. Let's talk about, this is the scan that your doctor does not want to see. So you can see on the right side of the liver, it almost looks like a spider web. That's what pneumonitis will look at. This obviously is a severe case. Overall incidence is 2.7% and considered uncommon. Again, I disagree. We see a lot of this. Grade 1 is asymptomatic, confined to one lobe of the lung, or less than 25% of the lung, or clinical or diagnostic observations only. So again, grade 1, we're actually just looking at a scan. Patients are not really feeling anything. We'll hold treatment or we'll proceed with close monitoring. We'll monitor the patients weekly, check pulse ox, chest x-rays, CAT scans if need be, repeat imaging in 3 to 4 weeks or sooner. And then we may resume treatment when we have radiographic evidence or improvement to resolution. If no improvement, we'll treat as a grade 2. Grade 2 is symptomatic or involves more than one lobe of the lung, or 25 to 50% of the lung parenchyma, or medical intervention indicated. We'll hold treatment until clinical improvement. We'll start prednisone 1 to 2 milligrams per kilogram per day, taper over 4 to 6 weeks. We'll consider a bronchoscopy. We may consider antibiotics if infection is still maybe in the differential diagnosis. We'll monitor weekly, consider reimaging, and if no improvement after 48 to 72 hours, we're going to treat this as a grade 3. We will consider pulmonary and infection disease consults if necessary. Grade 3 and 4 are kind of lumped together. Grade 3, severe symptoms or hospitalization required. Grade 4 is life-threatening, respiratory compromise. So we're going to permanently discontinue treatment. We may give antibiotics. We will be giving IV steroid improvement after 48 hours. We're gonna add some other immunosuppressive agents such as infliximab, mycophenolate, IVIG, or cyclophosphamide. We'll taper steroids over 4 to 6 weeks. We will have pulmonary and infectious disease consults as needed, and we may consider a bronchoscopy to see exactly what's going on in there if the patient can tolerate it.
When you have something like that, I mean, great.
I'm going to skip over the nephritis. And again, treated with prednisone. Oops, let me go back. Okay, so these are treatment options for the immune-mediated reactions refractory to your prednisone. Azathioprine, an immunosuppressive agent used for the hepatitis, the autoimmune hepatitis grade 3 or 4. It's given orally, 50 milligrams once a day, with subsequent incremental increase of 2 milligrams per kilogram per day. Infliximab, used for the 4 with either high-risk endoscopic features or with persistent symptoms despite the 3 days of prednisone therapy. This is given IV 5 milligrams per kilogram at week 0, second dose 2 weeks later, a third dose may be considered at 6 weeks. And this again is used in combination with your prednisone. This is contraindicated immune-related hepatitis because it does have liver toxicity. Vedolizumab, used for, again, colitis also, grade 3. And this is given IV at 300 milligrams at weeks 0, 2, and 6, and then every 8 if needed after in combination with your prednisone. Mycophenolate mofetil is like your super doll because it can be used for steroid refractory cardiac, hepatic, kidney, all of these adverse events by immunotherapy. Given 1 gram twice daily orally in combination with the prednisone. So key points to keep in mind: immune-related adverse events are common and often are manageable when and addressed in a timely manner. And clinical outcomes are not necessarily impacted by transient withholding of immunotherapy treatment and or the use of immunosuppressive agents. A lot of patients are like, Mary, don't stop. No, I need to keep going. Don't stop my treatment. Like when you need your lungs, right? You don't want a perforated colon, right? So you have to realize that holding it for a little bit is okay. We've stimulated it to the point where it's attacking normal tissue. We need to slow it down. And that is the end.
Okay. Okay. Then I did. No? Questions that,
Sorry, I should have stayed up.
okay,
I can jump in. I have a loud voice.
let's go to the next topic, okay? I think that, Vic had to answer the phone, so he's not going to introduce Mel. Mel, you want to introduce yourself? Since you're part of the organization. I'll let you do that.
Hi, everyone. Thank you for being here today. And I work as part of the surgery team with Dr. Eschner, ISPA. So we'll talk a little bit about surgery, wound management, and some things about how to take care of skin grafts. That'll fit. Okay. So from time, many of us notice lesions as in moles, and they look pretty funky, so we visit our dermatologist. A few things we usually, even in our office after they've seen their dermatologist, is my mole just, it's never really gone away. It's gotten bigger in size, it's getting darker in color, and you know what, it starts to bleed often. And so again, they see their dermatologist, and then they biopsy the mole, and there's a diagnosis of melanoma. I know a lot of this is repetitive, but I just want to go over this one more time. We have melanoma in situ, which is the early stage of melanoma, localized to the first layer of the skin known as the epidermis, as shown in this photo. And then we have more of an invasive melanoma, which has now invaded more into the deeper dermis, which is the second layer of the skin. So then the patient arrives to our office. And we do recommend, obviously, a wide excision, and if it's more of an invasive melanoma, we do talk about sentinel lymph node biopsy. And then obviously there are systemic therapies for people who have positive nodes, and radiation therapy, which is actually less common but reserved for people with more desmoplastic types of melanomas, as we know. So the patient has surgery, and the first thing I hear post-operatively is, why is my incision so long? That little small skin lesion ended up having this huge long incision. So we'll get into that. In surgery, obviously, in our practice, we follow the NCCN guidelines, which recommend peripheral surgical margins, as shown in this table here. So let's say you have a 1 millimeter thick melanoma. We're taking about 1 centimeter from each peripheral edge, top, bottom, right, left. We make a larger circle around that initial lesion, and then it's really hard to put the skin together if you don't actually turn the incision into more of an ellipse type, football type shape. And that is why you end up with a longer incision, just again to make the skin come together. We do need to make more of an ellipse shape, as shown in that photo over there. Another reason why incisions can look longer is to prevent dog ears, which are actually excess skin tissue at the end of the lesion. As you can see, if you turn the skin growth or we close the lesion more into an oval shape, the football shape like we just saw, as opposed to a more circle shape, you have a longer scar, but you prevent the dog ears or the excessive skin tissue at the end of the incision. The next topic is, so these are just more when we're actually able to put the skin together and we don't need to use any type of skin grafts, but there are many people who, given that the skin can be less, there can be more tension, less tension, so we'll get into why we would use skin grafts and where and why. So the reason we use skin grafts are typically for defects that can be closed obviously by sutures. They include high tension areas like your scalp, your forehead, your upper extremities like your forearm, and your lower extremities like your shin, your heels, your ankles. So if you really take a feel, it's not easy to pull the skin on your scalp, your forehead, your heel, and your ankles. So those defects need to be repaired with skin from other parts of your body. We have two different types of skin grafts. We have full thickness skin grafts and we have split thickness skin grafts. For full thickness skin grafts, those are when we actually repair the scalp, the forehead, the nose, the forearm. And we usually use skin from the lower abdominal wall because they are full of thickness and skin, and then we repair those defects. We use obviously split thickness skin grafts, and we use skin from the lateral upper thigh. So meaning if we want to repair the leg, we're going to use skin from the right upper thigh. If we want to repair the right ankle, we're going to use skin from the left upper thigh. So the lateral upper thigh of the defected extremity. So you come home and you come home to this, and you're wondering what that is. This is a bolster we often use for grafts. We use this petroleum-based mesh gauze with antimicrobial properties, which really helps to provide uniform pressure in order to avoid any mobilization of the skin graft. The patient will go home with this bolster for an entire week, and then they see us post-operatively, and we remove the bolster, and then we'll talk about how you actually take care of the graft itself. The photo actually is split thickness skin graft that's from the upper thigh. We typically get into how we take care of those. So the other three photos that look similar are bolsters, one of the foot, one of the scalp, one of the hand. And again, that's after a split thickness skin graft that we take from the upper thigh. So let's discuss the wound management of donor sites. For split thickness skin grafts, like the photo up here again, We really just typically tell patients to keep the area clean and dry. We don't recommend changing these dressings every day because the kid's skin is so fresh and sensitive and to peel off more skin if you change the dressing day. So we do recommend patients to only change the dressing when the tegaderm bandage is actually filled with fluid. So typically every 3 to 4 days, but every patient is different. And obviously to monitor for any signs of infection, including redness, pain, warmth to the touch, fever, chills, because they're all higher risk for getting infection. For full thickness skin, the ones that are coming from the belly typically, we advise for patients obviously to keep clean and dry. We put a pad, abdominal pad, to keep it clean and dry for the first 48 hours, and then they are advised that they can take it off after. The stitches typically stay in for 2 weeks. They'll see us post-operatively and remove their abdominal sutures or stitches in 2 weeks. Sometimes we take skin for the forehead from behind the ear, which is that photo over here. And those will stay in typically for an entire week. Obviously, we always advise our patients to monitor for any complications like postoperative seromas, swelling, infections, lymphedema. Picture of a split thickness skin graft, skin taken and meshed from the upper thigh, and that's a picture of a full thickness skin graft taken from the abdominal wall to repair the scalp. The wound management of skin grafts, I'm sure many of these materials look familiar to many of you. Always, it's very important to take care of your graft daily. It does require daily wound care, keeping the area clean and dry, obviously, and more importantly, to keep the graft moist at all times in order for it to stay viable. The way we do that could be through Neosporin-like antibiotic ointment or Zeroform dressing, which again is a petroleum-based mesh gauze with antimicrobial properties. And the most important thing many patients forget to do is really to shower. They're afraid to actually get that area wet because they think they're going to destroy the graft, but it's very crucial because if you don't, it tends to dry out and then scab, and then we run into issues of scabbing and dryness. So very important to get it wet. Obviously, there are always complications of skin grafts, which include infection and graft failure. From time to time, we do use synthetic skin grafts, and these are actually reserved for patients who will probably be operated on again. This is just a temporary skin replacement to cover the wound. There are many different types of synthetic skin grafts. There's one that's typically well known, and it's silicone-based, so you do have to watch out for patients who do have a sensitivity to silicone material, which may not be beneficial to them. Few tips about wound healing. Obviously, avoid smoking. Smoking, we know, delays wound healing. Avoiding sun exposure to your incision site. This can actually darken or pigment your incision. We never recommend that, even though we always say please stay out of the sun regardless if you have an incision or not. Avoid any heavy lifting. These are for people who actually have wide excisions on their arms, mid-back, high tension areas. Avoid any running or excessive prolonged walking for people who just came out of the OR with wide excisions of their lower legs and putting more pressure, which can cause swelling and other issues. We do typically get asked about some skin care for scars and how that can help. We typically recommend Mederma, which is a scar gel, or silicone strips as well. Few photos of well-healed grafts. This one's of the forehead in the middle, and surgical incision to the right, and then obviously you can't even see the incision of the armpit on the far left, which was a node biopsy site. Pretty easy, straightforward. So great.
Limes or bolsters or what?
Those are grapes from one of our
Oh, grapes,
patients.
great.
Which were probably the best grapes you've ever had.
Oh, that's right, yeah, thank you, Melody. We have time for questions and time for a patient panel. I lost one of my panel members who went home not feeling well. Questions for Melody? Then why don't we Maybe. Oh, yeah, yes. Yes,
Dr.
you have a question?
Margolis, you want me to go?
Hold on, we do have a question here.
How does the wound care relate to infection control with the different times you were showing?
How does it relate to?
The like infection control based on if you're doing like a silicone graft versus not doing silicone?
I think if you just have a synthetic graft to just begin with, your risk for infection is higher. So it doesn't really matter, but it is higher because you're introducing something foreign to the body.
Okay, well, we have Carl Lambert and we have Stuart Miller. Yep. Stuart Miller, yay, sweet. Well,
Okay.
you guys kind of, I mean, I'm used to having 3 or 4, but
Who else
it's
is
just
here? We could just stand right here by the mic.
or you guys can play tag. Yeah, the mic is just for the, you want to do that? Okay. We had a couple of.
Thank you very much. One for St. John's for allowing me to be here, and I don't mean just here. I mean on this planet. And certainly the team is great. And Dr. Esther, is the cat that gave me the first 9 lives, and that I'm here taking my next 9 lives. So I know I agree. Grandma, dad, and me, daughter, has had 4. She's only 32. And so also, I grew up before there was even sunscreen. I didn't see it. I was always out on a lake doing stuff. Got my first one at 40. Dr. Esther removed it. He said, maybe a 40% chance of coming back. Almost 15 years later, I got one. Then he said, well, you're now at 65%. After that, it became, we had another one almost a year later, recurrence right in the same spot of the back. And now I'm in the 95% time. So I had the opportunity to be part of the GMCSF study, which was almost 20 years ago. And now I did the Opdivo, had one minor recurrence after the first year. So now I'm doing the Opdualag. It's not that bad to do the Opdivo and the Opdualag. And, you feel bad for a couple of days, but you get over it and have a rose. And I report them and I get something that stops it. So it's certainly worth it. So I wouldn't be here today without this team, and they do collaborate, which is important. So thank you.
Thank you. Yeah, go ahead. Do people have questions they want to ask
Oh, go ahead.
Carl? Or, okay, you go up there, go ahead.
Come on.
No, go ahead.
Looks like we're.
Your turn.
It's your turn.
Okay.
Don't be shy. And if anyone else would like to, if there's anyone left.
Hi, I'm Stu Miller, out in the sun for 81 years. We are in good hands with Dr. Eisner, Dr. Margolis, and Dr. Simonian, I guarantee it. 4 years ago, I was diagnosed with the very same week. My brother Bill, who's 10 years older than me, was in the hospital for the exact same thing. We immediately I was fortunate that my bladder wall was good. My brother Bill's was not. His cancer spread, mine did not. We did surgery. I did BCG infusion, which was, in my case, it was a live tuberculosis cell that they inject into my bladder. And after 6 weeks, I was completely cancer-free. I went on 2 years of preventive maintenance. A year later, I ended up in my me to Dr. Eisner because I had he removed it. It was in fact melanoma. About 13 or 14 months transpires. I end up, my helper back here, Jesse, I end up in bed profusely for 20 days to the point that my blankets were wet. And so I immediately realized there was something going on because my stomach was swelling. I ended up finally seeing, because I was going to have spine surgery, epidural, not surgery again. And I sat down and my doctor said, Stu, you have liver disease. I said, how do you know that? He said, your eyes are yellow. That's when I saw my dermatologist, Eisner, after he operated. 14 months later, I ended up with melanoma inside on my liver and on my bottom of my lung, right? And now after, I would say 6 months of treatment, I am going to kick this thing. It is not going to kill me. I will guarantee it's not going to, because I'm in such good hands, number one, and this hospital, number three, I'm not going to let it get me. I do not, other than coming here for my infusions, I do not think about it. I do not use the cancer word. I use, to my friends, I have a malady if they ask me. And I said, don't even think about it. I don't think about it. If it gets me, it gets me. If it don't, it don't. Right now, it isn't gonna get me. Never retire. Because if you don't retire, you'll live forever. Because you gotta work forever. And that's how I live. And that's it.
Thank you.
We are all in good hands. It ain't gonna get me.
He looks good. Very detailed.
Can I ask, when you said you had 2 years preventive, what did you mean by that?
Pardon?
You said I had 2 years preventive.
Oh, that's for the bladder.
2 years of what?
Of preventive.
On the bladder?
I don't know.
Preventive. That's what I'm, actually, they, instead of every 6 weeks on the bladder cancer, okay, which is the first primary 6 weeks of tuberculosis cell, they then do it every 4 months. And you do it every 4 months until you get to the 2-year mark. And then after 2 years, they do a scope, which I don't allow the doctors to do at all because of urinary tract infection. I just say, hey, you know what? I'm fighting this right now. Let's forget about the bladder thing, and it's fine. So they do a preventive maintenance, of which I'll be doing here for probably
Probably
12, 14, 15 more months.
Yes. Yeah.
And then probably every year, listen, I'm gonna be doing this for 10 or 12, 15 years, this could be part of me. It just doesn't belong here, so I'm gonna get rid of it somehow.
Thank you, Steph.
If there's no more questions or discussions, we can continue with a thank you for everybody coming, and we'll find a way to get more people here and have a bigger room and more lively discussions and other speakers, because we've done this times, and we alternate this with seminars for for the basic science of melanoma, so we can all stay, and other skin cancer.
Is there any way that people can leave comments on?
Yeah.
Can we go to the website or whatever?
And we
That's
can,
always something they can just contact us, but we don't have anything in written form, so I would encourage everyone to use the website.
Yeah, just topics that people might want to hear. in future.
yeah, and you guys all know, I mean, you all belong to one of us, either Dr. Esner or myself, so you know how to find us on even just ordinary email. That's easy enough to do.
Will we be able to find this seminar on the, because there's a lot of information for us mere mortals to absorb. And I'd like to review some of it.
Yeah, the stream is recorded on our channel. You'll see our videos, and then under live, you'll see this video.